Welcome, everybody. This is Ed Gaines. I'm going to help host day two. A couple of housekeeping things. If you would please put us on mute on your audio unless you're speaking. Let me cover a couple of things. We want to thank our sponsors again, and ProAssurance, Logix Health, Zotec, and Gottlieb. We'll show those short videos in a second, but without them, of course, the course wouldn't be possible. And certainly I want to thank the staff, Belinda, Christy, and Maddie for all that they've done, and our faculty. Our faculty are among the most outstanding speakers in the college and supporting the college, and we're very blessed to have them, and I want to thank them personally for their involvement, and Dr. Gratson for his leadership. Again, reminder, if you could, please put us on mute. Please put us on mute. Thank you. Also want to remind you that you guys, bed availability. Guys, if you could please go on mute. Thank you before we start. Thank you. Please remind attendees that their name is visible on the Zoom so that staff can monitor who's attending for CME purposes. I will be monitoring the chat function and throughout the event and the speakers. So please keep that in mind and keep your questions coming in the chat. And with that, I want to welcome. First of all, let's turn it over to Maddie to do the sponsor videos, please. Thank you.
Our industry is changing. The rise in high-deductible health plans has shifted the collection risk to medical providers and made patients the fastest-growing payer. The business of healthcare has become a costly endeavor, but with the right partner and the right technology, the financial side of your business is taken care of, so you can take care of your patients. That's where Zotec Partners comes in. We're an authority in revenue cycle management and patient engagement for healthcare organizations. Getting claims paid quickly and appropriately is what we do, made possible with our industry-leading service team, unique processes, and fully integrated proprietary technology. Automation is at the heart of our direct-to-carrier claims filing and denial management with charge capture technology, so we can deliver accurate payments with rapid turnaround times for providers. Our extensive and proven patient experience model automates the process from registration to account resolution with mobile billing, so providers can effectively collect money from patients while meeting them where they are. Then we bring it all together with intuitive reporting and analytics technology to help providers understand and apply their data. And with compliance in SOC 1, SOC 2, and PCI DSS certification, providers and their patients can rest easy knowing that all levels of their organizational and data security are covered in every step of the revenue cycle. Bottom line, Zotec has helped hundreds of medical groups and healthcare organizations generate significant ROI with actionable results, removing the financial burden so they can focus on patient care. Think differently about the healthcare financial experience. Talk with a Zotec team member today.
Great, thank you, Maddie. And again, thanks to our sponsors. I'm really pleased to announce our first speaker this morning. He's new to the Straight Talk faculty. We're very fortunate to have him. Dr. Jason Adler is a practicing emergency physician at the University of Maryland with a decade of experience in coding and RCM. He's Director of Compliance and Reimbursement for the Department of Emergency Medicine at University of Maryland and Vice President of Practice Improvement at Brault. He continues to serve on numerous Edie PMA and ACEP committees focusing on clinical education, coding policy, and practice management. He's a fan of the second most messed up team in the NFL. That would be after the Lions, as a lifelong Lions fan. With that, turn it over to Jason. Welcome, Jason.
Thank you, Ed, for that wonderful introduction. Yeah. So when the Washington football team wins a game, there's a different feel in the DC area. Traffic is lighter. People are happier. There's less crime. It's been shown that there's less crime. We'll talk about a lot of data today, but that's something that we also have data on. Really appreciate everybody today. I appreciate the opportunity to come and speak about the opiate epidemic, talking about some financial management. And first and foremost, I just want to thank all of the work that the people on this call are doing every single day. This job is different than it was a year ago clinically. It just feels harder. It's tougher. 2020 is a tough year. And for the frontline workers out there, you're doing an amazing job and keep up the good work. It's just not an easy job, and really much appreciation to everybody out there. So I always like to disclose the fact I do work at the University of Maryland, but I also work for Brault Practice Solutions. I take a salary from them. Brault is a revenue cycle and coding and practice management firm. Goods and services with CME involved, always be on the safe side and disclose everything, and it's important to throw that out there. Whenever I give a talk about coding policy, and this is really a discussion about policy, it's about practice management, I never want to get too far away from the clinical floor, because that's what we do every single day. So I'm going to start with the case. You get a box call. I'm sure everyone else on the call has a box that looks just like this from EMS. Goes off. You hear about an overdose. EMS is activated to go to the scene. You have a 35-year-old male, apneic, suspected overdose, suspected opiate overdose. They give a little bit of Narcan, just enough to start some breathing, but still drowsy and somnolent. He's a little bit tachypnic. Heart rate's a little bit up. Blood pressures are soft, and they're on the way to your department. So you initially evaluate the patient. You perform an exam. You begin some end-tidal monitoring. And maybe or maybe not, you give some naloxone, but overall, you're watching this patient over the course of the encounter. Could be a few hours, could be a number of hours. Sometimes it depends on how much Narcan you give. They tend to want to leave very quickly if you give too much, but you're certainly observing them for a period of time. So today we're going to talk about the opiate epidemic and why it's trending in the wrong reasons. We're going to level set that as it is. And then we're going to talk about the 21 fee schedule. There might be some reimbursement opportunities to capture revenue for your practice for work that you're already doing, or perhaps should consider doing in the very near future. Whenever we talk about the opiate epidemic, we always start about the three-wave cycle. And really, if you go back to the 90s, and this is all about overdose deaths, the biggest cause was related to prescription medications. But then as you go 10 years later, we saw a rise in heroin and other drugs in that family. And in the past several years, we've shifted over from heroin over to the synthetics, the fentanyl, things that are coming, the illicit substances, the compound medications, and things that are coming from overseas. See this all the time now, but it's been a clear shift in the pattern that we're seeing in our departments. I'm focusing on what we see in the department every day, but I always like to bring in data when it's available. And just this year, the MMWR showed a nice study focusing on 2017, 68% of fatal drug overdoses involved in opiate in 2017. This is very real, it's very prominent, and we see it every day. And there is some correlation and overlap between opiate use disorder, substance use disorder, and mental health emergencies. Earlier this year, we see some good data showing that we have something that we see in the floor again every single day. Mental health related emergencies are more common with teens, young adults, and older adults in our departments. We're seeing this quite often, and this is all pre-pandemic. But if you shift over to the pandemic, alcohol sales up 25%. Urine drug screen detection for non-prescribed fentanyl up 32%. Urine drug screen detection for synthetic cannabinoids up. We have increased detection for methamphetamines and cocaine. There's just a lot more substance abuse now than there was a year ago, and we can show that. How about this? This was released about 3 weeks ago. Overdose-related cardiac arrests. Overdose-related cardiac arrests are up 58% in the middle of this year, from about April to July. This is EMS data. Up 58% overdose-related deaths. Real problem. But we've always been part of the solution, right? In the past several years, every department has their own process of going through. You've got departments, you've got systems, you've got groups. And our approach to this could be an ALTO, an alternative to opioids acute pain program. There's access to naloxone. I know I've seen more prescriptions of naloxone than ever I have in the past. We've reduced our pill quantities. We've integrated PDMP access. And we brought up some opiate metrics, feedbacks, monitoring the data. I've seen dozens of success stories across the country of groups that have really been successful in reducing the morphine milliequivalents that we are giving to patients at routine care from emergency medicine and the subspecialists, and it's being part of the solution. But context is everything. I want to take a step back and reflect upon this. So 5.3% of patients who are discharged after a non-fatal opiate overdose are dead at 1 year. 5.3% of patients discharged from a non-fatal opiate overdose are dead at 1 year. It's one of the highest risk discharges we do. So if you have a patient who comes in with chest pain and their heart score is 3, we will discharge them very quickly. In that case, their risk of a major adverse cardiac event, which goes way below death, is about 1.7%. Sometimes we'll get 2 sets of enzymes and drop it down to 0.9%. We're comfortable in that range. You get a heart score of 4, boom, patient staying in the hospital. And I work with systems when we do some data analytics where we look back at patients who are admitted for chest pain, and there are a lot of people who are admitted with a heart score that's 3. That's 1.7%. At the same time, people who come in with a non-fatal overdose of opiates have a 5.3% mortality rate in 1 year. All cause. Very significant information. There's lots of reasons why it happens, but it's just a very high risk discharge. But there's value in offering medication-assisted therapy. Here's the citation. I have a lot of citations for review. I hope that slides could get disseminated afterwards. So MAT makes a difference. We know we have a problem, and the fee schedule may offer some opportunities. Outpatient treatment programs, there's a lot of information about that, not directly related to emergency medicine, but I wanted to bring it in to bring up a few points. In 2020, it's a new benefit category for opiate use disorder. And for 2021, they're extending the definition of opiate use disorder treatment services to include Narcan. And then there are add-on codes to cover the cost of Narcan. There are frequency limits, and that's being discussed. But the message I see here is in 2021, where most of these conversations about reimbursement, about practice management, about the specialty of emergency medicine, we hear so much about cuts, decreased resources, decreased opportunities. This one area is being funded and funded well. There's an emphasis on opiate use disorder. There's an emphasis on substance use disorder. It's being financed. And I do think at some point we will get funding to get reimbursed for giving take-home Narcan kits from the emergency department. So there's funding, And now we're talking about naloxone a lot more than we have in the past in the fee schedule, which is very powerful. Let's bring it down a layer into our emergency departments. So this came from the fee schedule directly as supportive evidence in the comment section about how we got to our new codes and what opportunities exist. Direct quote, patients who receive information about drug treatment in the hospital post-overdose are more likely to seek treatments. We know that, it's in there. More patients engage in treatment after the ED-initiated MAT versus referral alone. This is the validation to open up a new code, citations available as well. So final rule for MAT, initiation of medication for the treatment of opiate use disorder in the ED, including assessment, referral, and arranging access to supportive services. Again, initiation, assessment, and referral. Initiation, assessment, and referral. That's what we're talking about. It's an add-on code, G2213, and it's worth 1.3 work RVUs, which plus or minus, depending on your location, is about 1.89 RVUs. Now, an add-on code goes on in addition to your evaluation and management service, your observation, your critical care. It goes on top of that. And we're oftentimes doing this work already. It's page 541. Also from the fee schedule. In response to which elements, what are the documentation requirements? What elements are required to build this code? Practitioners should fully furnish only those activities that are clinically appropriate for the beneficiaries being treated. That's code speak for medical necessity is your guiding force, right? Do what's appropriate for the patient and we will take care of you. So here are the questions that I have, and I'll throw it out here first. We may get more clarification from the MACs with specific requirements of how we define these three variables. But there are a number of groups, big groups, that are working on policies to start this January 1, working off of the information we know today. So what is initiation of MAT? Well, we would all agree at this point that providing a prescription is initiation of MAT, prescription being most likely buprenorphine or Subutex. Those are the two most common. We don't really use methadone, that's a separate bucket, not really often done from the ED, but Subutex and Suboxone, buprenorphine is something that we do and do quite often. And remember that because of the Support Act, we are able to give one pill per patient per day. But as of 2 weeks ago, there is new legislation being passed that we can give without the X waiver 3 days of medication. I think at this point, 2020, moving forward, the likelihood of any individual ER doc getting that X waiver is raising every day. I got mine several months ago and have used it quite a bit. But a prescription is the marker of initiation of MAT. There are questions as whether a prescription for Narcan or naloxone can be considered part of initiation of MAT. That's being discussed. Don't have clear guidance just yet, but based on what was referenced with the OTPs earlier, there might be a linkage there that is one part in the process of MAT that may be included. So a prescription for Narcan may be in play. An assessment, there's no reference about using a CAL score or the DSM-5. I would recommend everybody not try to reinvent the wheel. If you're looking at initiating an MAT program, the Yale School of Medicine has a wonderful website that goes through a really thoughtful way of breaking each of these components down. Not about reimbursement, just about high quality patient care.
I got everything in my brain. And then some.
And then referral. We do referrals all the time. We can do that. You can have an expert counselor see the patient. We can offer referral to an outpatient treatment facility or another facility. But the three variables, initiation, assessment, and referral, it's really starting a medication, performing some form of assessment, and offering referral. Again, 1.3 RVUs work-wise, and then up to 1.89 plus or minus for total RVUs. High value, medication works, and it's high quality patient care that could literally save a life. For practical application, let's go back to that case that we started off in the beginning. So we had the patient that had an overdose, brought in, got a little bit of Narcan on the way in, wasn't combative or violent, actually was more somnolent and drowsy, low respiratory rate. We started some end-tidal monitoring, watched them in the department, and took care of them. So most of these cases are going to fall within that 992X category, but most likely 99285, maybe a 4, depends on your clinical vignette. But let's not forget, if you give Narcan, if the patient's hypoxic, if the patient is on end-tidal for a while of time, and you're concerned about them, a lot of those patients might end up in the critical care bucket. End tidal monitoring is a triggering event for critical care, and you're watching them. It's more of a passive mechanism compared to BiPAP, which is an active mechanism, but it might be in the critical care bucket. We also have observation, and we don't talk about it as much. And when I talk about observation, I'm not referring to a CDU or observation units. We're talking about pro-fee observation for patients that stay in your department, shifting over from the 99281 to 285 code series to observation codes. The definition, most importantly, is when time is a diagnostic tool, and polysubstance abuse and mental health are in 2 of the top 5 most common utilized codes for observation in the emergency department. We're not changing anything on the facility side, but it's just what it is in the ED. So if you're watching somebody and you're observing them, you could code it as observation, which has a minimal documentation requirement and can potentially reimburse a little bit higher. Have seen this trend escalate over the past several years, where many groups are doing this all the time. What is the value? So it depends on what code you end up in, but if you're looking at a critical care code, you're looking at 6.36 on the 2021 fee schedule, plus the 1.9, you're looking at 8.8 RVUs. If you're observing the patient from when they come in, you cross midnight, have that discharge code 217, you're close to 9 RVUs to 10 plus RVUs for one patient. And really, it's not necessarily about the RVUs, it's about the high quality care, and it's accurately capturing the work that you're doing. If you're watching somebody for a period of time, and time is a diagnostic tool, observation is an appropriate code set, and it does reimburse fairly well. This is a supportive reference for everybody. CPT assistant last year, this is more on the mental health side of things. They give a nice clinical vignette where a patient comes in with a mental health emergency. They get medically cleared, psychiatrically cleared, recommend inpatient care, but there are no beds. Patient's basically boarding. And CPT assistant in this vignette recommends using the observation codes. And if you look at what they're saying about that vignette, you look at what we're doing with the opiate patient, you look at what we're doing with a number of other similar vignettes, there's good grounds to support using the observation codes for these patients. So what does this all mean, and where do we all go with this? So COVID has been consuming our lives for the past year. But there's a less visible epidemic all around us, and we can be part of the solution. We already are. We're doing the alto. We're taking care of the patients. We're either observing them, we're watching them, we're already starting MAT programs. And in treating a patient with opiate use disorder, starting MAT can literally save a life. And going back to industry, practice management, coding, and policy, it can also support your practice, increases accuracy, and can potentially increase revenue. That's a lot to unpack. I have my information down below. I know the slides will be disseminated to everybody, but I just wanted to stop for a moment to reflect and offer the opportunity for any questions.
Hey, Jason, did you see, we've got a question in the chat from Dr. Gratzen. Do we have clear guidance yet on what type of documentation is required to bill for the G2213?
Yeah, it's a great question. We're working through that. Right now, it's initiation, assessment, referral. So the referral piece is easy. The assessment piece, I think, is easy. It sounds like something you could just say what you did. I don't like using the word template, but there could be an area of the medical record where you document that the patient came in with a potential overdose, meets or does not meet criteria for opiate use disorder, or if they're in withdrawal, you can reference a CALS scale. That's why I brought in the Yale website, because they did a really nice job of breaking that out. But that's your assessment piece. The referral piece is literally just a referral. And the fee schedule does describe that emergency medicine is a good opportunity to capture these patients and get them into treatment. So you're part of that continuum of care. So really the biggest question that I'm waiting for the MACs to come out with is about the initiation piece. I'm fairly confident that writing a prescription or giving some buprenorphine, if we can do that 3 days, would be in that, meet the requirements for initiation. Whether Narcan counts, a prescription for Narcan counts, that we're trying to find more information for. The MACs generally give guidance over the next several months. Most things that I've seen today and commentary I've seen today has focused on a prescription related to MAT, a phrase about your assessment, and providing that referral. And that should be where we are.
So big picture, this is work that you as an EM doc are doing today and do every day and have not been getting credit for. And the good news is, starting in 21, based on ASAP and EDPMA advocacy, you're going to get paid for, subject to details from the MAC.
Yeah, I believe so. And I also believe that private payers will follow. We haven't gotten into that, whether the Medicaids and commercial plans are going to follow the same pathway.
Right.
What I can tell you, especially with Medicaid, this is more about opiate use disorder than the G code, but Medicaid has a ton of funding and a ton of grants. They're funneling money into this topic. So I think it's valuable for any emergency medicine group to become more familiar with initiating MAT, more familiar with this devastating crisis, and more opportunities that we could offer our patients to provide that high quality care, because I do believe there is funding available. Everything we hear today is about funding getting cut. Everything's getting cut. This is actually getting funded, and that's a good thing, because these patients need us and we could help. That 5.3% is terrifying to me. And among that 5.3% that have an all-cause mortality in 1 year, about half of them have fatal overdoses within the next 2 to 3 days. It's very quick. So if we're going to discharge patients with heart scores 3-, and people do that, I think we have a great opportunity to elevate our quality of care, get the waiver, bridge people over to definitive care, and do what we do. So this is a fascinating subject. Thank you, Ed.
Great. Thank you so much. Any other questions in the chat?
Yeah, I have a question, Ed.
Sure.
And this is for you, Jay, or maybe not as much a question, just kind of some information to let people know. You know, the state of Michigan has also really highlighted the need to provide better treatment for patients with opioid use disorder, along with looking at emergency departments as really being that touch point where we can really intervene and make the difference. So there's actually quite a bit of grant money that's available through the Michigan Opioid Partnership. If individuals are interested in getting funding for a particular project, maybe they want to create, hire on a specific person that would really work directly with these patients in your emergency department. They can provide funding for that. I know that's something that we here at Beaumont Health, we were fortunate enough to get a grant through the Michigan Opioid Partnership to be able to do things like that. So there's a lot of good work to be done in the space, and there's certainly, just like Dr. Adler had mentioned, there's an interest in providing the financial resources to really enable emergency departments to be effective at treating these people. So, it's a good opportunity to really make a difference and, secure additional funding.
Great. Thank you again, Jason. Great presentation. If you would stop share, I'll bring up my deck, and organizationally we will, I'll go next, and then we'll have a break to visit the vendors, and then we'll come back with Dr. Powell and Mr. Thomas. So please keep those chat questions coming. Let me share this. And let's see here. Are you seeing a full screen? Anybody?
Yes.
Okay, great. All right, so I'm going to talk today about COVID-19, the impact on the CARES Act and the public health changes. And I've got some very good news just breaking literally in the last 10 minutes that I want to share with you. My faculty disclosures: I am an officer. I'm a vice president of regulatory affairs for Zotec Partners, and we are an ED revenue cycle and practice management company. All right, so the 2020 virtual meetings, and we've all been here with Zoom. Relief at seeing other human beings, 23%. Removal of the cat from the keyboard, 7%. Maybe if I move the camera up higher, I'll look better. Actual meeting content. We hope we exceed that here at Straight Talk. Here's probably we've all been in this situation where you forgot you had the Zoom meeting and you have the Zoom meeting and it's baseball cap time. But then we have our British grandmother, first to receive the Pfizer vaccine outside of a clinical trial last week. Very good news, and great to see the number of docs that I follow on Twitter and talk to that are receiving the vaccine as we speak. All right, objectives. We're going to talk about the Provider Relief Fund, patients over paperwork, some of the changes in the Stark rules, what's changed and why, and what hasn't. We're going to highlight some fee schedule final rule changes, some of which have been made in the context of the public health emergency, and then also do Q&A. All right, so at the risk of going back into one of the worst years in history, since the 1918 Spanish flu outbreak, I am a history major with a particular set of skills, so we're going to do some of that and go back to the early part of the year and talk about kind of what hit us and where we are. But from a big picture perspective, several things to think about, and these are very hot topics as Congress is debating a new round of COVID relief. So this was back in April. This number has definitely gone up since then. Almost 13 million workers have likely lost employer-sponsored health care, which means that they converted over to COBRA if they had it, or they converted to Medicaid if you're in a state like Michigan that has Medicaid expansion, or if you're in a state like mine in North Carolina that doesn't have expansion, you may not be covered by Medicaid. You may have to buy your insurance in the ACA exchange. And then articles just about what's happened with unemployment. This is as of September. And again, I think this number's probably gone up significantly. So we've got some tsunamis that are hitting us. I call them reimbursement tsunamis. So you've got the run out of COVID relief, the triple P, which I'm not going to spend a lot of time on. Most of what's happening with the Paycheck Protection Program is now kind of moving into what I'll call the accounting phase, and you need to consult with your accountants and your legal advisors about that. But there's possibility of new rounds of triple P coming. COBRA benefits, as I mentioned, those are unfunded, so the employee's paying both the employer portion and the employee portion. And so many of those covered lives, as COBRA runs out and is unfunded, are converting either to Medicaid or self-responsible. So this was Dr. Mike Presley, who spoke at EDPMA workshop last week. This is Sound Physicians, over 1.5 million visits. And it just shows you the macro impact of COVID. And Dr. Gronowski showed some of these statistics yesterday. So in the early January, February, they were trying to get over 18,000 visits a week. And then at the end of March, early April, that dropped almost 50%. And look at the decline from literally mid-March to the first week of April. It's really stunning. And of course, it was counterintuitive because I think many expected there would be a surge of patients because of the pandemic. Then it trended up, and now it's still trending at about 13,000, which is still almost 30% below what they were trending at in 2019 and the beginning of 2020. So these numbers really confirm a lot of the data that we've heard. This group has hospital relationships in half the states in the US, so pretty good indicator. Now, the reason I'm showing you this letter is when we heard about the CARES Act, ASAP and EDPMA worked very hard, and I have to credit Drs. Randy Pilgrim, Dr. Tony Cirillo, and others who were very busy and active in putting together what the ask would be for CARES Act relief funds for all of emergency medicine. The bottom line on that ask was $3.6 billion. And it was $2.5 billion in lost volume, as you can see here on the right. And that was based only on 4 months of lost volume. Remember, this was early April, and then increased expenses. So the ask was $3.6 billion. This is important for reasons that we're going to touch on in a few minutes, because we're going to come back to this. All right, so CARES Act 1 started $175 billion for hospitals and clinicians, in late March. These are grants, not loans, to both doctors and hospitals and others to reimburse for necessary expenses or losses that are attributed to coronavirus. Key thing to remember about CARES Act Provider Relief Fund is this is a fund of last resort. And if you have available funding, say from the PPP program or an EIDL loan from HHS, those funds have to be used. The Provider Relief Fund is a fund of last resort. So Tranche 1, we know, was issued in mid-April. It was 6.1% of the 2019 average Medicare reimbursements. You didn't have to do anything. They just sent the money in. But it came with terms and conditions. And one of the terms and conditions was no out-of-network balance billing. As a condition to receiving the funds, unless you paid the money back, and some groups did, you could not balance bill the patient. You had to take the in-network cost sharing and apply that to the patient, and that was it. All right, so that was Tranche 1. Tranche 2 came around, and Tranche 2 was an additional $20 billion. So we had the $30 billion of Tranche 1, the $20 billion of Tranche 2, total package here now of $50 billion from the CARES Act. Additional monies for hospital hot zones, rural areas, and Indian health, and then another $30 billion, folks. That's 9 zeros. $30 billion for testing and treatment and the uninsured program, which I'll touch on. So also SNFs and dentists. So Tranche 2 came up with a formula, and the formula was that you should get, as a group, up to 2% of either your 2018 or 2019 gross revenue. You had to go to the HHS website portal, you had to upload your tax return, and then they calculated based on this formula how you would receive that money. And I give an example of one group and how that formula worked out for them. So again, here, the Provider Relief Fund, same terms and conditions for Tranche 2 as Tranche 1, and then we move into where we are today, which is Tranche 3. Now, Tranche 3 was continued with the 2% theme based on 18 or 19 annual revenue, changes in operating revenue, operating expenses, but they included new clinicians who hadn't started practice before 1/1/20. They also included dentists, oral surgeons, behavioral health, and assisted living facilities. So groups that hadn't received their 2% were kind of first in line to have a true up to that 2%, and then they would distribute additional CARES Act money to the remaining groups. Now, those applications were due on November 6th. I just received word, literally 15 minutes ago, that deposits are being made on Tranche 3 into physician bank accounts. Let me repeat that. Tranche 3 monies have started to be paid as of today. We don't have details, but in some cases, for some of our groups, it is a substantial amount comparative to Tranche 1 and Tranche 2. We have been saying for some time to temper expectations, given the fact that you have a whole group of new clinicians, dentists, oral surgeons, behavioral health, assisted living, now in that category, but now we're seeing these monies being paid. So be on the lookout, talk to your practice managers, your bankers, see if you're getting those monies. But remember that 2%. That 2% is going to be a potential ceiling. So if you were at or near that 2% before, you may not be getting much in the Provider Relief Fund. So reasonable expectations, nope, don't see them on the gear list. So keep advised. Now, very important, whether you get Tranche 3 money today or in the next few days, if you've received Tranche 1 and 2 and it's over $10,000, and I'm sure it has been for nearly every group, then you're going to be required to report. And that reporting starts here January 15th, and it closes on February 15th. Sorry, let me go back to that. Closes on February 15th. Now, we had practice managers and CPAs on an EDPMA workshop last week. They said very clearly that one of the safest categories to use this money is the payment of malpractice. They also, one of them mentioned RCM costs. So here's where you absolutely have to consult with your accountants and legal advisors about this. You want to make sure this is government money. You're going to have to report. You don't want to be in a position where you're doing any kind of false or in error reporting. All right, what else is going on relative to the CARES Act? Well, it was both the CARES Act and the Family First Act that said that testing, per se, testing, COVID testing, will be paid at no cost sharing to the patient. Medicare, Medicaid, TRICARE, Medicare Advantage, and commercial health plans. So testing paid at the full allowable, no patient cost sharing. But those acts envision that a diagnostic is used. So what happens if in the early days this was true, testing wasn't available, and in the early days it was true that a lot of EM docs were skeptical of the false negative or false positive results, so that they didn't have a lot of confidence in the testing. So what about it? So know that under those two federal laws, the use of the diagnostic test is key. Now, one of the things that we've recommended, and Dr. Jason Adler, who just spoke, was very helpful in helping craft this. It was really his brainchild, was to come up with a macro for our clients to use early on if they suspected COVID or they knew that they were going to test that patient, and really helps you, I think, you from a medical legal standpoint, but also from a practical coder standpoint. For the coders in the audience, if you see that macro in the EMR, you know the doc's thinking this is a COVID patient. And in the early days, there was a lot of unknowns about these patients. So I think this is just one example, by no means exclusive. You can come up with your own, but we inculcated this with our hospitals in many of the EMR systems so that the docs would know. Plus, it helps us on the back end when we're dealing with a health plan that says, oh, wait a minute, we're not responsible for paying 100% of the allowable. It's like, well, yes, here's the macro, and here's the evidence of the test that was done, and we have a grounds for appeal. So this helps you on the back end as well. So think of it as both a front end help and a back end help. All right, so what's happened when you're talking about treatments, okay, treatments without testing? And as this lawyer in Atlanta said, it's very much of a bouncing ball. So here's, boy, we thought before that the health plans changed their policies a lot. They've changed them a lot in this area. And the question here is, what do they have to pay for treatment? What do they have to pay for treatment when it's by telehealth? Do they have to pay for treatment via urgent care? So this organization on the left is AHIP, the American Health Insurance Plan Association. This is their national association. That link will take you to a website, and listed there alphabetically is every plan that is an AHIP member. All of your blues are in there. United Healthcare, Aetna, Cigna, you name it, they're all there. And you can see what their policies are. And folks, their policies are all over the map. So remember, testing, they have to pay at the contract rate or the cash listed price on the provider website. That's for testing. And for treatment, a lot of the plans initially, we're talking about March, April timeframe, said that they would waive cost sharing for physician office, urgent care, emergency department, telehealth during the public health emergency. Let's stop there. So the PHE, federal law, allows for the Secretary of HHS to declare a public health emergency, which he did back in the spring. It's been renewed a couple of different times. The current PHE is scheduled to run between now and January 23rd. Fully expect that either the existing secretary, if he's still in office, or the new secretary, if they're confirmed, will issue probably another PHE extension. It's 90 days. They may issue another one after that. So during the PHE, these plans said, we're going to pay for treatment. But then now, as we approach the end of 20 and 21, when you look up at the AHIP website, you see, for example, UHC, waiving patient cost sharing for COVID E&M services for testing and treatment, but only through October 22nd. Anthem plans, health plan affiliates, continue to waive cost sharing if you're in network with Anthem for COVID-related treatment and testing, okay? If you're in network. So if you're out of network with Anthem, then that policy doesn't apply. and contrast that with Aetna. Aetna says, we'll pay for you if you're in network or out of network for treatment of COVID-19 through 6/1/20, and telehealth cost sharing is waived through 12/31. So again, somebody asked me recently, could we get a grid of all the health plans and their various policies as they relate to payment for testing and treatment? And I said, gosh, I really wish we had a grid like that, because it would be great to have. But this is going to create a lot of challenges for your back-end RCM folks and the folks that do their own billing in hospitals. This is why there is so much confusion. And you can imagine the patients, patients don't know what they should be paying or not. And as we're approaching the vaccine, here's an important question. It was a great article in NPR about, well, can employers mandate testing? And this lady here owns a restaurant in the Seattle area, and she has told all of her employees who have been furloughed for 7 or 8 months, she said, unless you take the vaccine, I'm not hiring you back. So the question is, and I put this in my tweet, is this a new civil rights issue? It may be, as we see with the vaccine. But let's be clear about one thing. Back in 2009, none other than the Occupational Safety and Health Administration, OSHA, said, unless there's a medical or religious exemption, an employer could require an employee to take the flu vaccine for the novel H1N1 influenza A, which OSHA notes is genetically distinct from the seasonal flu virus. Now, you could draw a very close analogy between the COVID vaccine and the vaccine for novel H1N1 from a policy legal standpoint. It's not a big jump to say that OSHA would similarly require an employer may allow for an employer to mandate the COVID vaccine. Now, we've heard from hospitals initially just in the last week to 10 days that many hospitals are leaving it up to the individual person to decide if they want to take the vaccine or not. But many of you are business owners, and many of you may have to look at this issue and certainly recommend that you consult with your counsel as well about this. Okay, so some other important CARES Act reimbursement provisions: liability protections for clinicians who volunteer during the public health emergency, EMTALA waivers during the PHE. Now, let's be clear, EMTALA has not gone away because of the public health emergency. What HHS has said through CMS is hospitals may establish an alternative location, a tent, for example, or an outbuilding, to do the medical screening exam, abbreviated as MSC, provided the approach is consistent with the state's emergency preparedness plan. So typically, outside of a public health emergency, you cannot have a separate screening process for different patients, right? That, generally speaking, is not permitted. But under the public health emergency, it is. So hot zone, cold zone, you do medical screening for your hot zone in maybe a tent or a different setting to create separation there. Perfectly acceptable during the PHE. The Sequester Cuts. These are negative 2% on all government expenditures, including Medicare. They've been in place for many, many years. They've impacted you and they impact other federal government spending. In March, with the CARES Act, the Sequester Cuts were suspended from May 1 until the end of this month. Without congressional intervention, however, that negative 2% is going to layer on top of your negative 6% in the fee schedule that Dr. Gronowski and Mr. McKenzie talked about yesterday to total you at a negative 8. So that's one of the things that we're advocating for a reversal of. The other thing to keep in mind is under the CARES Act, hospitals receive a 20% add-on plus 20% for their inpatient services related to COVID testing and treatment. However, back in September, CMS came out and said very clearly there has to be evidence of a positive COVID test in the inpatient EMR. So you want to be sure, and I'm sure hospitals have told you this, from the clinician standpoint, that positive COVID test is listed in the EMR. Now, importantly for our purposes, ICD-10 and the ACEP Coding Nomenclature Committee has made this, I think, very clear in some of the announcements that they have generated, is ICD-10 does not require a positive test to use the COVID code. That a clinician can make a clinical decision that the patient is presumptively COVID without the evidence of a positive test. So very important to remember that. All right. Now here's something to think about as Congress is debating potentially hundreds of billions of dollars coming to the states, and that is a state provider relief fund. So this is something to be thinking with your leaders at MSEP, and if you're in other states, your state ACEP leaders, is how can we potentially access some of the billions of dollars that may be coming out of the COVID relief package. In North Carolina, here they did something very similar. They just increased the fee schedule on Medicaid by 5%, and they retroed it back to March 1, and they said it will continue until the PHE expires or nearly the end of March of 21. They also funded through the North Carolina Medical Society Foundation up to $120,000 to $160,000 in group physician group purchase of PPE. So they funded PPE purchases through the foundation. You just had to apply. The groups just had to apply. But here's a really creative idea. So Dr. Lisa Maurer from Milwaukee, Wisconsin, active in ACEP and EDPMA, she did a presentation last week to EDPMA about how the Wisconsin ACEP chapter went to the state and said, hey, we think you should use some of your provider money coming from the CARES Act specifically for EM groups. And so they first of all had to identify who were the EM groups, and then find out how they're eligible and how do they separate out the EM groups from the hospitals with the place of service 23. And then they define their categories for decreased revenue, which they could show volume decreases, of course, depending on your locale. And then a number of other categories. And she said one of the biggest was the amount of medical director time that was spent by their medical directors to prepare and deal with COVID, to deal with creating the hot zones, the tents, and the other facilities to address the COVID patients. So I think this is a great idea. I think there's some opportunity in 21. Definitely need to be thinking about it and contacting legislators and saying, okay, well, is Washington giving you specific money to support providers during the pandemic? If you don't ask, you don't get. All right, so a couple of other things in the fee schedule quickly. So moonlighting residents, if that resident is working outside their approved GME program, then the services are separately reimbursable if they otherwise meet the conditions for payment. E-prescribing controlled substances. This was required by the Support Act, and this is coming, but compliance deadline was extended out another year to 1/1/22. So good news there. Telehealth. Due to the public health emergency, CMS adopted the interim final policy to revise the definition of direct supervision to include the virtual presence of the supervising physician. This is during the PHE. So be mindful of when the PHE is with us and when it's not in terms of telehealth and supervision. So they finalized this proposal through the end of December of 21 or the year in which the PHE ends, whichever's later. All right, then payment for services of teaching physicians outside of a metropolitan statistical area. They finalized a proposal that was instituted during COVID-19 that allows the teaching physician to supervise residents remotely using telehealth, provided the residency training site is outside of an MSE. An MSE, general plain vanilla definition, is an area plus or minus 50,000 in population. So in my old hometown of Ludington, if there was a residency program at Memorial Hospital in Ludington, they would qualify as being outside a metropolitan statistical area. It's not easy, as Dr. Gronowski said yesterday, always to determine what is an MSA and what isn't. All right, the Gypsy Floor, very briefly, the Gypsy Floor. Gypsy is a geographic price cost index that applies to the elements of the RBRVS fee schedule, the work, the practice expense, and the medical malpractice. It has had an artificial floor for many years of 1.0. Going back to my analogy to my old hometown, if you're in West Michigan, my guess is the Gypsy in West Michigan might otherwise be below 1.0. It certainly is in some rural areas, but in the law, it's been established artificially at 1.0, and it looks like it's going to be extended. It was extended in the continuing resolution. We're expecting that it's going to be extended again in the omnibus that's coming up. Okay, a couple of just quick reminders on patients over paperwork. We've covered some of this in the past, so some of this is review, some of this is a little different. We're going to talk about the Stark and anti-kickback. You'll remember this slide from previous lectures, but this really shows that the Secretary of Health and Human Services has CMS and OIG both underneath it. You have the U.S. Attorney's Office, very active in health fraud. Then you have the MACs who are contracted with CMS below that. And then look at the fraud and abuse recoveries, nearly $12 for every dollar invested. All right, so effective on 1/1, the old rule, this was the pre-January 1, 2020 rule, was the student, PANP medical student, could only document the past family social history review of systems. If they documented other elements, the emergency physician was required to perform and redocument those under the current policies, and that was transmittal 1780. As of 1/1/20, the students can make notes as part of the medical team, and the supervising physician needs to review and verify, sign and date. They don't have to redocument. So that was a patients over paperwork reform. All right, what's not changed? What's not changed? The split shared visit policy, and this is from transmittal 1776, which says if I am a PA working with Dr. Adler and he wants to bill the service at 100% of his Medicare fee schedule, he has to personally perform a substantive portion of the E&M service of the patient that I see. So that has not changed in the patients over paperwork reform. And here we see an old settlement. I shouldn't say it's old settlement. It was actually from last year. It was from 2019, but it was pre-change of the rule. And in this case, the settlement was, hey, you can't just write seen and agree as the supervising physician for a PA and get 100%. That's not a substantive note. That's not a documentation of a substantive encounter. So it's important that you create a timeline, kind of a Venn diagram of here's what's changed and here's what hasn't, so that you avoid these problems. Okay, again, by way of review, pre-2019, what was the requirement for teaching physicians and residents? There was a requirement that the teaching physician document the extent of their participation in the review and direction of the services furnished to each beneficiary. That was required pre-2019. Then along came the 2019 final rule. And what CMS said was, this part that's in gold above is the teaching physician still has a participation performance requirement, if you will, but the documentation standard has changed. Now, the documentation may be demonstrated by notes in the medical record by physician, resident, or nurse. So a member of the care team can document that participation, but the substantive performance requirement has not changed. That's key to know. All right, so what's not changed? Again, we're talking about what's changed, what's not changed. Critical care documentation by the resident doesn't count for critical care time for the teaching physician. That's transmittal 1780 and 811. That has not changed. We mentioned split shared visit, not changed. Major minor procedure, not changed in the documentation, transmittal 811. So again, you need a grid to know here are the categories of things that have changed, and here's the categories that haven't, and keep up with that. It's challenging, but it's something we really have to do for our clients and our groups. All right, I've talked about EMTALA. I'll just touch on the Federal False Claims Act. We've talked about this before, and I'll also summarize very quickly the anti-kickback statute and Stark. Stark really deals with the referral of by a physician of designated health service. And then does the physician have a financial relationship? And does that financial relationship meet an exception? So that's really the start to prevent self-referral of items or services paid for by Medicare. Anti-kickback, on the other hand, says it's really prohibiting the physician from receiving any, quote, remuneration, anything of value for either inducing or rewarding referrals of services paid for by the government and payers. And it's critical, folks, that you get good advice here. We see Stark and anti-kickback come up really not often in the ED context. It is coming up in the telehealth context. If you own your own telehealth solution and you're referring patients to your emergency department, that's immediately potentially a Stark question. Look at those 3 questions. Potentially a Stark issue, potentially also an anti-kickback. The other area it comes up is medical director stipends. So medical director stipends. Is that medical director stipend at a reasonable fair market value? And here, the government's actually helped us because they've said that they've tried to draw very bright lines about what is fair market value. And they say valued in an arm's length transaction. So there are firms that do this analysis. There are CPA firms and consulting firms that will do fair market value analysis. That may be something your hospital wants, maybe something that they require as a condition for your stipend. But also know that they've tried to amend these rules, and there isn't time to get into this, within the context of alternative payment models. Certainly the ACEP awesome model and other models, they're trying to amend these rules to be able to function in that context. Just know that the multiplier on the False Claims Act is big in ED because you see so many governmental payer patients, and the multiplier is per claim, and that multiplier is nearly $11,000 per claim. So my example here, you can have 300 claims that you either should have known, knew or should have known were false or fraudulent, or you were deliberately ignorant of those, and it's over a $3.2 million penalty. So just remember that. There's provisions for relators who can get both attorney's fees and up to 15 to 30% of the recovery, and know there's an anti-retaliation provision on that. All right, I'm going to just touch on TPE. We've talked about TPE in the past. This is Targeted Probe and Educate, and that's all about the MAC taking 20 to 40 claims, looking at those claims, doing education, and then coming back through the process again if they don't see a significant change in the practice. Now, good news is that a lot of the MACs have suspended TPE. Here is your latest grid, something that we provide to the House of Emergency Medicine every year. This is the CMS data. It's only CMS fee for service, not Medicare Advantage. It's only physicians who are in specialty designation 93 emergency medicine. So if you're family practice or internal medicine, you're not in this data. And you can see, look at the critical care services in 5 years, over 200 basis points in growth. So we would say, yes, the patients are sicker, and particularly with COVID. The government looks at this and says, well, is this a result of upcoding or buffing the charts, or is it due to something else? So here's your Michigan graph. So you can, again, see a pretty steady state increase in acuity. One thing that's definitely increased is Medicare Advantage, and that certainly has impacted that data. Here are your 5 levels of appeal. Again, I mentioned in the TPE context, we don't have to worry about this as much right now because TPE has been suspended. Now, I spent some time, and maybe folks in the audience know this. I cannot find in the WPA's website that they have put their TPE process on hold. If I look at the First Coast Service Options MAC, they have done so. If I look at Novitas MAC, they have done so. They both put their TPE process on hold. I did not see any of that. Interestingly enough, WPS has said that they've suspended certain education. So I don't know how they can do a targeted probe and educate program without education, but we'll see. But this may come back certainly in 21 after the PHE is over. So it's something to think about. Finally, if you do get into a situation where you're in an audit and defending an audit, and you're dealing with extrapolation, that's applying that error rate across the universe of claims, know that there's a new OIG study that may help you. So if you appeal that extrapolation methodology, you may just have to pay back the overpayment and not the rest. So, all right, remember your PRF reporting requirements. We just saw some deposits made this morning. Good news. Possibility for audits in that coming up. There are some PHE specific changes. Also note the Stark and other changes that have been in place. And that the TPE and other audits are likely to resume in the next year. Here's my contact information. Again, happy to take your questions now or offline. Here's my email contact. And with that, I will transition out. And we will transition now to the virtual visit with the vendors. Let's see, Maddie and Christy or Dr. Gratson, will they get prompted to go into one of the vendor rooms?
Yeah, thank you very much, Ed. So if you look in the Zoom chat, we do have links to our vendor partners. So I certainly encourage everybody to get a chance to get some FaceTime with our partners here. You know, as Ed said at the beginning of the day, this conference wouldn't be possible without the support that we have from our sponsors. So please spend some time with them. They're all very great and they have a lot of interesting things to share with us. After you spend time with the vendors, just note that at 10 o'clock, we're going to get restarted. If you go back to your email and use the Zoom link that you used to get into this Zoom session today, just make sure you do that by 10 o'clock. In addition to that, please note that in your email, you did have a brochure with all of these links here for our sponsors. After you go to one sponsor, if you want to go check out another one, that Zoom chat is going to clear for you. So please use your email brochure to get your additional links. But we'll reconvene at 10 o'clock and use this opportunity to spend some time with our great partners here. So thank you.
If you're not speaking, put yourself on mute. We want to thank again our faculty, the staff, Belinda, Maddie, and Christy for all that they've done, and certainly our sponsors, Logix, Pro Assurance, Zotec Partners, and Gottlieb for their support. And with that, I will turn it over to Dr. Powell and Mr. Thomas. Take it away, Don.
Thanks, Ed. Can you hear me?
Yes.
Okay, great. Well, thanks everybody for this morning. I kind of want to give a quick thanks to Ed as well as Dave McKenzie and Mike Granofsky, because I can't imagine the amount of work that has to go into preparing for this conference, especially since the final rule has just been released within the last week or two, often before this conference, and just massive amounts of information that they have to go through to prepare for us. So here in Michigan, we're very fortunate to have such great experts and such up-to-date information. So thank you very much for that. So that being said, my name is Don Powell. I'm an emergency medicine physician in Grand Rapids, Michigan, part of a group called Emergency Care Specialists. And I'm lucky to speak with Todd Thomas, works at ER Coder. Many of you know is just an expert in the field of coding. So we're going to talk a little bit about telehealth here and kind of go forward. Some opportunities potentially on the horizon as well as here today. Many experts in the field of telemedicine will say that really the PHE has expedited the utilization of telehealth probably as much as 5 or 10 years in the future. So it's really exploded, as you can imagine, with all the exceptions that CME as well as private insurance has allowed in revenue and payments. So estimated this year that telehealth revenue can be up to $20 billion in 2020. And a lot of the statistics I'm going to say are not isolated just to emergency medicine. They deal with telehealth on the whole throughout the universe of the medical field. It's estimated that by 2025, their revenue is up to $60 billion. So with that being said, you can see the statistic there that from August 2019 to August 2020, telehealth utilization has increased over 3,500%. So just astronomical increases. And as a service line, really, most of us feel that the telemedicine service line won't fade after the PHE. You know, patients become accustomed to certain expectations and services, and many feel that our customers are going to expect this as an option for them in the future. And if you don't have a telehealth program or accessible one, or one that you can tap into, there are going to be some potential issues you may have just with this PHE. If there's future ones or any areas of disasters, you potentially are going to have a hard time participating in those. And with certain alternative care models like Awesome model that CMS has proposed, you're going to have, or that's proposed by ACEP to CMS, you're going to have difficulty participating in those. As far as CMS, currently there's about 253 telehealth codes. Since the beginning of PHE, CMS has added over 135 different service lines. And these include expanding the ED visits to include levels 4 and 5s, initial inpatient and nursing facility visits, and discharge management services. We talked a little bit earlier about MAT. We talked a little bit about the ability to provide teaching services to residents across telehealth, and many psychiatric and behavioral health codes have also been added. Many benefits to go along with telehealth. There's possibility of improving patient care. Mainly this revolves around speed of access. You know, how many patients do we see that for whatever reason have not presented until late? They couldn't see their doctor, they couldn't get their antibiotics, they couldn't follow up. This potentially is a way that they can access care in a more easy way and quicker way. And also as a way that potentially they can eliminate need for transfers if they clinically deteriorate. There's a lot of crossover between ET3 and other options out there to combine telehealth to provide lower cost of care. And everybody's looking for lower cost alternatives to the ED, and this may be one of them. It also has the potential to increase access to care. Many in the rural communities just aren't able to see their primary care doctor, or they don't have a primary care doctor, or they don't have easy access to an urgent care center or an ED, or they're mobility impaired and they don't meet criteria for EMS transport. This might be a great opportunity for them. It also allows you to expand the hospital ED model. All the hospitals that we partner with obviously are concerned about leak or loss of those patients to other systems. This might be a way that those individuals or those patients on the periphery can still access care through your system. Now, I know we talked a little bit about Stark laws and referral back into your system, and that's a whole nother discussion. But this is a way, depending on how your system's set up, to garner those patients back and keep them in your system. Also, it allows, we talked about a little bit, APM participation with the new Awesome model and improve patient satisfaction. You know, this is the reality of our lives, right? I know lots to be said about the millennials and their likes and dislikes, but bottom line is they're a subset of our patients that know what they want, when they want it, how they want it, and how they want to pay for it, and it's low cost, right? And telehealth meets a lot of those criteria. You know, the other issue is that we hear this on a regular basis, both from primary care, from insurers, from the government, that everybody wants to decrease ED utilization for the low acuity visits, you know, those levels 1 through 3. We're seeing increased payer denials with PLP issues. We're seeing the Autobots and the diagnostic list down codes. We're seeing escalating high deductibles for those deemed low acuity visits from the payers. So there's a lot of pressure. Now, I'm going to talk about this a little bit here and a little bit in my next lecture, but you know, I think we just have to change our mindset. We can choose to give those patients up, or we can choose to manage those patients, but maybe outside the walls of our traditional 4 walls of the emergency department. Telemedicine provides a solution to recapture those minor conditions. CMS and commercial payers are currently providing payment of parity. When I say parity, meaning that they're agreeing to pay the same for a telehealth visit as they would as an inpatient or an in-person visit. And many of the originating site restrictions, which really have hampered telehealth utilization in the past, have been lifted, at least during the PHE, and we'll see what happens thereafter. The other issue with telehealth is it's a great way to provide service to COVID patients, both from a safety standpoint for the patient, but also for the practitioner. And it's also an option for those providers that have been quarantined and aren't able to work in the department that continue to work and provide care that's needed. It's the clinical challenge, though. It's not so much as, okay, I have a group of providers that can do telehealth. I've got a platform, at least in thought, and I have a billing company. They should be able to take care of it. Let's go. Let's set up a program. Realistically, that's not where we're at. The telemedicine program is technically fairly difficult. It requires 4 to 5 simultaneously running software programs. You need a registration software. You need ability to consent the patient. You need a billing software. You need a video portal. You need an EMR or some way of storage, data, electronic data storage. You need an e-prescription modulation, and you need discharge instructions. So quite a bit goes into the actual setup of providing a telehealth service. Also, licensure. This has become a little bit easier. Most of the individuals that provide telehealth provide across state lines, and it used to be very difficult and very expensive to license yourself in each state that you want to practice in. But now there's been development of licensure contracts or compacts that allow multi-state jurisdiction and registration and licensure. The only caveat that I would say to that is almost every state in telehealth has some different regulations and rules. If you're going to practice across state lines, or your group decides that this is something that you're interested in, then you really do need to designate an experienced credentialing professional to stay ahead of this. As far as online prescribing goes, again, it varies by state. Most states do not consider just a simple online questionnaire sufficient to establish a patient-provider relationship. Some states allow telehealth to perform a physical exam, others do not. Some are silent about it. Some states have relaxed requirements on controlled substances and medication-assisted treatment. I know Dr. Adler talked about this and the great need. Here in Michigan, we have, as of now, the ability to, for Suboxone treatment, induction, and follow-up treatments with telehealth. As far as methadone, induction still requires a person-to-person initial induction visit, but after that, methadone follow-up visits can be through telehealth, which is huge. There's also a trend towards legislation of directing healthcare professional boards to adopt standard prescribing practices across telehealth. Now, again, this is MGMA data. This is not isolated to emergency medicine, but I thought this was a great statistic that 97% of healthcare leaders report their practice has expanded telehealth amid COVID. So just huge implications and utilization increases. Telehealth is not just a U.S. issue. This is global. I like this pie chart on the left that shows that the blue is U.S., but you can see the red portion is Europe, as well as Asia Pacific and the Middle East. All are actively using telehealth in their treatment to patients. The far right graph kind of shows you that there is a huge penetrance, whether it's telemedicine vendors and platform individuals. We have telehealth groups that are providing providers and the actual service line. We have multiple payers and startup payers. We have medical device manufacturers that are finding ways that patients can provide vital signs, EKGs, listening to their heart and lungs through telehealth capabilities. Retail clinics are also getting into it. So it's greatly expanding. A couple quick definitions we should be aware of. Originating versus distant site. CMS has required that telemedicine services include both an originating and a distal site. Distant site. Bottom line is the originating site is the location of the patient at the time of service, and the distant site is the location where the licensed provider is located. Now, in the past, CMS has pretty strict criteria of what can be an originating site, and that's been primarily the one of the main utilization issues with this. And CMS has said in the past, those sites include Office of the Physician or Practitioner, hospitals, critical access hospitals, rural health clinics, federally qualified health centers, hospital or critical access hospital-based dialysis centers, skilled nursing facilities, and community mental health centers. It's been only recently that we've seen that the home can be an originating site for PHE, and we'll talk a little bit about that and its ramifications. Parity laws, basically, again, parity is where a carrier decides that they would pay they would provide services or pay the same for inpatient or in-person versus telehealth visits. Now in Michigan, there is parity laws for benefits, but there's not parity laws for reimbursement. That being said, a lot of those parity issues have been stayed or amended in the face of the PHE. Currently with PHE, we have the ability to use Edie E&M level codes 1 through 5. There are currently 3 buckets or code sets that CMS is using. The first set is those codes which CMS proposes to be approved permanently. There's a second set of codes or a second bucket that CMS proposes to be included to the remainder of the calendar year following the PHE. So if the PHE ends in March of 2021, those would extend through December 2021. And that's where our current levels 4s and 5s E&M code levels reside. And then there's a third level, which CMS proposes removing once the PHE ends. Of that, one of the biggest, again, utilization issues is the geographic and originating site requirements are going to be no longer waived once the PHE ends. As far as Medicaid goes, all 50 states and DC currently reimburse for some types of audiovisual telehealth services. The store and forward, the remote patient monitoring, telehealth or telephone only, those are really lagging. Many restrictions still hamper utilization, again, primarily located around originating site. Some of the states have dropped Medicare's rural geographic requirement. We talked a little bit about that earlier today in Ed's lecture. And many Medicaid programs limit the type of facility that can serve as the originating site, mainly the home. Now, there has been some movement towards that. Again, currently PHE is alleviating some of that issue, but 27 states have already permanently allowed home to be the originating site in the future under certain circumstances to be defined. And then 26 states allow school-based setting as originating sites. Now, this is very interesting because I think during Dr. Gronowski's lecture yesterday, he mentioned the decreased volume that we've seen across our patients, but the huge decline that we've seen in our pediatric patients. So this might be a way, again, with the thought of expanding outside of our 4 walls, that we could capture some of our pediatric visits back. Regarding the billing itself, there's 2 potential payments. One, the telehealth facility fee is paid to the originating site through HCPCS codes, type 9 service. There's the RVU payment revised for 2021, and provider can be paid through a claim of the distance site through our 1500 form. Now, there's multiple care models that potentially you can institute. There's the ED provider to patient, there's a consultant to remote triage for a follow-up post-ED visits, extended care facility, and in concert with EMS. And we'll talk a little bit about each of those. First of all, I think this is what most people think about, the ED provider to patient. Typically urgent care service, ad hoc as needed, a click per pay type program. And any of us that have been involved in telehealth in any form know that that is a very, very difficult way to make a living and make any kind of profit. That, for the most part, that's a money loser. Unless you're part of a national program that has multi-state coverage, that is a very, very difficult option. Now, potential options that may be more applicable or more profitable would be pre-contracted applications like with prisons, schools, clinics, employer health benefits. And we'll talk a little bit about this in my next talk, where potentially you could be the medical gatekeeper for an employee health plan. And basically how that would look would be anytime that a patient needs a service that they contact you through some type of telehealth program, you can talk with them, whether it's an urgent need, an emergent need, or none, and you can coordinate care, potentially a much safer, less cost generating visit. And obviously another option would be that if you put a telehealth in a fast track and ED where you had nursing staff, obviously radiology, phlebotomy, and techs there, but you could provide services through a telehealth service. ED to consultant. Many of our rural sites have non-boarded EM services there. Some of them have only APP services after certain time periods. This might be a way that we could provide telehealth consultation and expertise to those rural sites. We could provide potentially subspecialty expertise in areas such as peds, tox, and psych, and expertise to oversight to other clinics like workman's comp clinics and just urgent care clinics as well. ED provider as a remote triage. Certain areas have instituted this where there's a telehealth station right in the triage area. It requires a kind of a group or a triage team where there's a nurse, a tech, maybe phlebotomy, maybe radiology, where the provider is able to interact with that patient at the same time the nurse is inputting the patient through the ER. You're able to get some initial diagnostic studies ordered, put them in the right location in the ER, and once they're there, the on-site provider takes over. Kind of a high-level medical direction, if you will. Another option is ED provider for post-ED follow-up. In this situation, the patient agrees to a follow-up plan, and the patient is provided information on technical aspects, how to access the apps, the website, is it telephonic only, and the ED provider follows up in a set period of time. This is kind of the idea of the ACEP awesome model. It can promote patient satisfaction, potential early intervention. How many times did we see where we see a patient with cellulitis, pneumonia, etc. We send them home. They don't start their antibiotics for whatever reason. They can't get to the pharmacy. They can't get to their follow-up. They don't take their Lasix because it's a mobility issue. Multiple areas where we intervene earlier may save them a repeat ER visit. It may save them a repeat admission. So, and it's a reduced follow-up cost. Next would be ED to extended care facility. There's a lot of good ideas, and many telehealth programs have already started this, where you have a pre-contracted service or an arrangement with the extended care facility. It allows you several things, and you can be as aggressive as you want or as aggressive as ECF wants you to be. You could be part of the early triage evaluation and treatment team. For instance, the COPD patient that has an exacerbation or maybe an early pneumonia, early fever, respiratory issues. If, the middle of the night, right now, the way it works for most ECFs and SNFs is fever, shortness of breath, boom, stamp, send them to the ER. But if we could touch base with those patients and say, they might do okay with a Duaneb, let's start some steroids and see how they do over the next few hours, supplemental oxygen, and have the primary care or the nursing home physician see them in the morning, might save a transfer. We might, the classic one, I'm a night-only ED doc, and one of the things that I always see that frustrates me is I get the feeding tube that falls out at 2 o'clock in the morning, and they reflexively send them into the ER, and I don't have GI or I don't have IR that's able to replace that peg for another 6 or 8 hours, where if I could touch base with them and they're not, they don't need that for nutrition immediately or meds or, sustenance, that potentially I could get them follow-up in the morning with the correct service that would be able to replace that tube on an outpatient setting and save the ER visit and the transfer fee. Studies early on have shown that both transfer and subsequent admission rates can be decreased by as much as 10%. I think as we start doing this more and more, that number is going to be much higher. And again, it's an ideal reimbursement for a per member per month through the ECF or some type of contracted agreement with the insurer that provides that telehealth service some kind of regular sustained income. ED provider to EMS, I think a lot of us have heard about ET3 and whether or not this extends over the next 4 or 5 years or not. I think that once this is instituted, it's probably going to be here to stay. It allows providers to see the patient in their home environment or wherever they're being transferred from, review initial data, EKG triage, initial management, etc. And it allows easier adaptation of pre-hospital defined care plans, and again, the potential to prevent unnecessary transports or help transfer coordination to other settings, low-cost settings. Other options, and not all these have to be done by high-level provider, right? Some of these can be done by social work or potential nurses, where you could orchestrate chronic care management, advanced care planning, and even smoking cessation. Ed talked a little bit about this in his last lecture. Most of the carriers instituted some type of a laxity, whether it be with originating site, whether it be with patient copays and out-of-pocket expenses. These have waxed and waned since the PHE. Some have ended, some continue. But there has been some good progress. I mean, Cigna released a new permanent telehealth policy effective January 21st to cover it on some coverage. Again, many have extended the coverage through the PHE. So I will touch a little bit on denials too. That's been a question. Was in an EDPMA conference last week, and they talked with some of the big carriers or telehealth companies, and they're really not seeing denials from the carriers. They've been pretty good. The denials that they've seen have been the same kind of denials that we see through the ED. Kind of good news that we are seeing appropriate payment and parity payments when they say they would. Those that are interested in telehealth in kind of Michigan, and I refer you to this site, the Center for Connected Health Policy. It's a wealth of knowledge on telehealth. You can dial down on your state, and if you're interested at all, you can always contact me or take a look at the site. And from here, I'm going to turn it over to Todd Thomas.
Thank you, Dr. Powell. So I'll talk about telehealth a little bit more from a coder's perspective. So just some kind of regulatory stuff. Telehealth services are interactive telecommunications. We do have to have audio and video communication with the patient. CMS does allow the provider or the patient to use mobile devices that we typically refer to as phones. And during the PHE, the Office of Civil Rights has said that they're going to exercise some enforcement discretion regarding HIPAA violations for contacting a patient through everyday technologies like FaceTime or Skype. That being said, I would caution against ED providers contacting a patient via FaceTime or Skype, because then that patient has your direct contact information. I would encourage you to work with your facility to set up something a little more secure than just sharing your contact information. So for telehealth visits, for a true telehealth visit, the patient and the provider are at two separate locations, either the provider's at the hospital and the patient's at home, or another location, or the patient may be at the hospital and the provider is at home or another location. This really provides an opportunity for maybe some of our colleagues that are on quarantined or not or in a risk category that doesn't let them work shifts in the ED. They can help with patient management from home and do that telehealth service for patients that present to the hospital. They could manage that patient via telehealth from home. The encounters where the patient and the provider are at the same location, meaning both of us are at the hospital, but we're going to use some kind of a telecommunications to do part of that visit so that we can limit our face-to-face exposure for patient or physician safety, and to cut down on the use of PPEs, are not actually billed as reported as telehealth visits. I kind of call those hybrid visits. And we have several groups that have gone to something like this where, the physician may do their initial evaluation at the bedside, but then once they've left the room and stripped off the PPE for that patient, their follow-up evaluations, their discharge summaries, discharge instructions, they'll do those either through an iPad app of some kind or even through the telephone or monitor in the patient's room. Now, if we're going to report our ED visits as telehealth visits, the performance and documentation requirements for those visits is the same as a normal ED visit. Okay, we haven't been given any abbreviated history or exam requirements to report those as telehealth visits. So we're still going to have the same, 4 HPI, 10 review of systems, 8 systems in a physical exam type requirements for our higher acuity visits. One of our colleagues on the ACEP's Coding and Nomenclature Advisory Committee developed this no-touch exam that can be used either for a true telehealth visit or even for the hybrid visits that I mentioned earlier, where you don't want to go into the room, but what's an exam that I could do from the doorway or through the window to meet the requirements for a higher acuity exam. So here we have just general appearance of the patient. If it is one of those hybrid visits, we can review the vital signs that were taken by nursing staff or at triage. We can evaluate the eyes, check the mucous membranes, evaluate respiratory by looking for chest rise, just visual indications of respiratory distress, accessory muscle use. Capillary refill, have the patient do their own capillary refill test. Comment on distension, or have the patient or someone else tap on their abdomen. Look for range of motion or deformity for musculoskeletal. Ask the patient about certain activities to evaluate their neuro evaluation. Do an observation of their mood and effect, and then a visual observation of their skin. That's 8 systems. So theoretically, that's a comprehensive, or not theoretically, mathematically, that's a comprehensive physical exam that would, from a coding perspective, support a level 5 visit. And then what I did is I went through the 97 E&M guidelines. We don't really mess with the 97 guidelines as emergency coders very much because they are pretty detailed. But then the advantage to that level of detail is I went through and I pulled out just the exam bullets that are something that could be done either via telehealth or from the door or through the window that could be considered part of a no-touch exam. So again, we've got constitutional, just general appearance of the patient, ENT, just an external inspection of the eyes or nose, assessment of their hearing, which with a telehealth visit could be troubling if it's just, turned up the speakers on your computer, assessment of respiratory effort, cardiovascular and visual examination of their extremities for edema. Musculoskeletal could just do a visual assessment of range of motion, skin, visual assessment, skin and subcutaneous tissue, rashes, lesions, ulcers. We can evaluate them for orientation to time, place, and person, their recent remote memory, their mood and effect. And then some of the neuro exam can be done, pupils for eye movement, facial symmetry, tongue protrusion would get us the neuro exam. So again, that's 8 systems that would support a higher acuity visit. During the PHE, CMS has amended the teaching physician guidelines to allow telecommunications to be part of our process. So the teaching physician can do their supervisory role of a teaching visit via telecommunications per CMS. The teaching physician must provide supervision either with a physical presence or be present through interactive telecommunications technology during the key portion of the service. So it can't just be a telecommunication visit or discussion with the resident. The teaching physician still has to interact with the patient. So there would need to be that direct attending to patient contact, even if it's through telecommunications. This is an attestation that we worked with one of our groups to set up for those telehealth visits or the telehealth supervisory visits. And you're welcome to implement that in your practice as necessary. And they've also given us an allowance on billing for interpretation. So if we do our own EKG, X-ray, ultrasound interpretations, that can still be billed if the interpretation is done under telecommunications. However, they do tell us that the teaching physician still has to review the resident's interpretation. So the requirements for billing and interpretation with a resident involved is that the resident reads the interpretation, documents their interpretation. I'm sorry, they read the tracing and then document their interpretation. Then the attending physician has to also read the tracing or look at the film and review the resident's interpretation and then either edit it or agree with it as appropriate. So that requirement hasn't changed. So we still have to meet both of those requirements, but it can be done via telecommunications. With respect to procedures, they have not relaxed the requirements any. They tell us that the teaching physician must still be present during the critical portion of a procedure and immediately available to furnish service during the entire procedure. They feel that given the complex nature of procedures and the potential danger to the patient, even within the context of the PHE, the requirement for physical presence during the critical or key portion of the procedure is still a necessity. So if the resident is doing the procedure, the attending physician does still have to be directly and physically involved in that procedure. With that IFR that came out back in the summer, CMS did modify the supervision requirements for PA services performed in the hospital setting and tells us that the physician supervision can be done through a virtual presence with audio video communication technology. So ASAP asks, so hey, that applies to the office, but can we do our shared services in the same way? And via email, CMS confirmed that we can do our shared service supervision face-to-face encounter with the patient via telecommunications and bill that as a physician visit and get paid at 100%. So from a coding perspective, it's fairly straightforward for an experienced ED coder. We're going to use the regular ED codes, 99281 through 99285. CMS has instructed us to use the place of service that we would have normally provided that service. So we're going to report those as place of service 23. And then any service that is provided as a part of a telehealth visit, we need to attach modifier 95 when we report that service. And I think that's all I've got for you. I would certainly encourage you to contact Dr. Powell or myself if you should have any questions about telehealth. I certainly, am open to answering your questions on telehealth or anything else you guys have related to coding and ED documentation. I'll open up the floor to see if we have any questions. I may check the chat. I don't see anything there. So absent any questions, I will refer you back to Dr. Powell for our 10:30. But while we do the transition, if you guys have any questions, feel free to speak up. But then we also have the open question and answer at 11 o'clock. So I'll be around for that also.
Thank you, Todd. Thank you, Don, very much. We will now transition to Don talking about additional revenue opportunities. I want to thank him and Todd again and all of our faculty for their participation. All right, Don.
All right, let me just transition over. Oh.
I mentioned the provider relief fund distributions, just so everybody knows. HHS has now made a release on those distributions, so I will post the link to that in the chat. This is, again, tranche 3. So mention that tranche 3 monies have started to be received today. So good news.
Great, thanks, Ed. Can you see my screen?
Yes.
Okay, great. So we're going to talk a little bit about ways you can maximize your revenue stream going forward. I think that, this is the reality, and this is a scary kind of whirlwind we're looking at. But, as Ed and Dr. Gronowski kind of outlined over the last day or so, that, we're looking at some pain here. We're looking at CMS conversion factors cuts, 6-8%. You're looking at our just terrible Michigan surprise medical bill legislation that got passed. We're looking at potential national surprise medical billing legislation that may not be favorable, that will encompass our ERISA plans. We're looking at increased PLP violations. We're seeing Autobots and auto downcoding. We're seeing increased patient payment responsibilities. And as we all know, that's basically like trying to collect from a no-pay patient. We're looking at ED volume decreases. We're looking at increasing options to ED visits, such as telehealth that I talked about, and other bad behavior. So, not a lot of good news on the horizon, unfortunately. So I'm going to throw out something here that's probably going to set you back a little bit, but this is something that, we looked at through our own group in the last year or so. And I want you to think about that with the idea that all our providers at least want to maintain their current hourly rate. What are you going to do in the face of declining revenue from almost every aspect? So we kind of threw this number out here, and it really shocked me at the beginning, but I think that as we kind of walk through this, you see that there are potential opportunities. And think about in the next 3 to 5 years that 50% of your revenue comes from non-ED revenue sources, non-traditional, see the patient in the ER, charge E&M levels 1 through 5, or 99281 through 99285. 50% of your revenue going forward potentially needs to be from another service. A lot of, if you're like me, that scared the hell out of me initially, but I think there are options, and again, we'll talk about a little bit. As far as first thing we're going to talk about is observation. Observation is here to stay. It's only growing. When I first started talking about this, probably 8-9 years ago, observation was only a few groups using it sporadically throughout the state. I think most of us are using observation in some form, and it's only growing. The traditional observation model is an extension of the ED. We're sharing space, providers, nursing, social work, and other resources. There's usually cross coverage with an attending or an APP. As most units have fairly limited diagnostic lists, and basically CMS states that the same physician is the same specialty or group, so that if you're seeing a patient in ED, you're charging an E&M level, and then you're converting them over to observation, you're only able to capture that E&M level or the observation codes, but not both. The traditional model, pretty easy to institute. Some additional documentation required for observation, mainly around past medical history, surgical history, social and family history. Basically, you got to add a family history, so you get 3 out of 3 there. Provider satisfaction, if you're the patient, if you're the doc or the provider putting the patient into observation, pretty easy. If you're disciplining on the back end, maybe not so much. Again, really minimal financial incentives. So why have an observation unit then? Is, really not a lot of incentive, can be a hassle. There are really any true benefits. And the benefits are really multifactorial. From the ED side, it improves ED throughput, it decreases boarding. I think most of us that have units will see that, we admit a patient to the inpatient service, and that patient can be boarded in the ER for hours waiting for the bed, where if they're an OBS admit and we're running the OBS unit and they're moving beds anyway, then that patient disappears within a matter of a few minutes. Decreased provider risk, increased patient satisfaction. They get some answers immediately. We're able to rule out, major issues, whether it's cardiac, stroke, etc. Again, provider satisfaction is somewhat variable. If you're the dispo obs guy that doesn't know a lot about that patient, hasn't established a lot of rapport, and you're going in a report and basically, here's your answers, it's time to go home, sometimes that can be a little bit more difficult. Hospital administration satisfaction shows you're a team player, and it can help your contract. And again, the potential for an additional revenue stream, and we're going to talk a lot about that. So from the hospital, it also has benefits as well. I'll show a slide here next that there's really been a huge increase in facility reimbursement for observation. The 2019 comprehensive observation services payment is a little bit shy of $2,400. Improves metrics, increased ED throughput, decreased level of stays, decreased time admission to the floor, decreased hospital length of stays, and decreased readmission rates, which is especially huge with certain things like bundled payments and CHF, where the hospital is penalized for those readmissions, where we can potentially put them in observation and stave off that admission. The other thing is it by decreasing boarding and put them into an observation status, especially if it's a unit that we're running, it can potentially open up other hospital beds for a higher paying DRGs. We talked a little bit about satisfaction, not only from the patient, but the provider and the staff. Consultant satisfaction, those of us that have the units, I think that the consultants love our observation unit. I think they love to use it for more things than we're capable of doing, just because we bring that EM mentality where, you know, we got an issue, we're going to deal with it, we're going to move on. And it allows transfers from outlying sites. You know, it increases the hospital footprint. Our facilities have a couple hospitals here in town, and they, like many hospitals, have consolidated services, and one of the service lines that we've consolidated is cardiology. And it allows us at our secondary site to transfer those chest pain patients directly into our observation unit to provide that care for them that would be very difficult at that original site hospital. And again, multiple reasons to justify support from the hospital. So this is that graph that I was talking about that's shown, God, wouldn't you love that our payments through E&M looked like this over the last 10 years. But in 2010, comprehensive services were paid about $700. Currently, through 2019, a little bit shy of $2,400. And the reason that CMS has been able to do this is because this compares to the typical 2020 hospital payment of a full admission of just a little bit shy of $6,000. So we have a dilemma. Is there another business model that we potentially can use that can capture both of those payments? And this is where it gets exciting. So from an alternative observation model, this potential model would allow capture of both the Edie side and the observation side. It would allow additional and expanded accepting diagnostic lists, and it would allow potential for alternative service lines, and we'll talk about that as well. It does require a dedicated observation team approach with providers, nursing, social work, and discharge coordinators, and those last two really are critical for the success of the unit. So a couple things, I'm not going to get in too depth with this, but most patients that are going to be admitted either to observation or traditional admissions are going to be a level 4 or 5 or critical care. So kind of put in your wheelhouse the 99285, rough Medicare payment, $175. So from an observation standpoint, if you see a patient seen admit greater than 8 hours, discharge the same 24-hour period, not to cross the midnight. Again, most of our patients from experience that we put in observation are high acuity, so the 99236 is going to pay around $220. If you look at that from a multi-day stay, again, at the high acuity of the 99220, the intake day is 185 roughly, the subsequent day 100, and discharge day about 75. So by potentially how do we go about capturing both of those? And to do that, you need to establish a new entity, a new corporate entity, a new TIN number. This is pretty easy to do. So a few steps that you have to run through, and I'm going to run through this quick so we can get to kind of the nuts and bolts. But those of you, I kind of presented this in the past, and the slides are here for you to review. But basically, establish a corporate entity. It's quick, it's fast. You do it through the state. You also need to apply for a new TIN number or EIN number through the IRS. Again, short online application, easy to do, nominal fees. Now, you can get lawyers involved with this. It's only going to increase your cost. It's really pretty easy to do with the office staff that you have. The other thing you need to do is apply for a new NPI number through CMS. Again, short, easy to do, nominal fee. And then once you have all that set up, you have your new entity set up, whether it's a totally new entity or a subspecial or a subunit of your primary company. You apply for group insurance enrollment and contacts. You apply for provider insurance enrollment. You establish a new bank account lockbox, accounting services, and back office support. Again, quickly, how easy it is through the online services. Again, you can access these slides. I'm not going to spend a lot of time on them. This is how you access through the irs.gov. And then finally, attaining the new MPI number, the link's at the top right. So this alternative observation model, the how-to approach, you're going to have to file a separate tax return. And again, if you're set up as a subsidiary, then it can be incorporated into your consolidated tax return. You're going to need to acquire malpractice insurance, workman comp insurance, general liability insurance. And again, these can all be rolled under your existing parent company policies. So how does this look in reality? So you see a patient, they present asthmatic patient, wheezing, accessory muscle use, hypoxic. You see them in the emergency department. You give them Duoneb steroids. fairly robust workup, chest x-ray, EKG, etc. You decide that, you know, they're better, but they really are going to need admission or at least observation. So you decide to admit them in observation day 1, discharge them the second day. So how does this look in reality, the way the current models run? So if you'd see them through the ER, probably at least a level 5 chart there. Let's, you know, for ease of following, let's just look at Medicare numbers, or maybe now with Michigan, the new surprise medical billing, that 150% Medicare number. So level 5 chart's going to be 175 or 260, depending on what model you're looking at. Or you put them into observation for a 2-day stay. You're either going to garner about 260 through Medicare or 388 through that 150 model. But if you could capture both of those, you're looking at capturing the full Edie service, and we'll look at just Medicare at 170. You capture the 260 OBS charge, and the combined charge, you're looking at 430, or the 150 Medicare upwards of 650. So you're not. I don't look at this as gutting the system, right? This is actually just getting paid for what we are doing, which I think is going to be more and more imperative as we start to see cuts more and more. So the staffing model is likely going to be an evolution of dedicated providers to the service. You can do physicians, APPs. It's going to require nursing, MSW, and again, DC planners. Now, there can be 100% crossover from your ED group with observation. Now, I would seek your legal support from this. We did seek legal, and what we did to kind of abstain, or to cut the concerns of self-referral, is that we only work in 110 and 124-hour time period. That way it's not looked as self-referral. But again, we would suggest you seek your legal guidance. We do suggest dedicated CME, you know, that it's available now through observation courses. It's just a little bit different than our traditional ED patients. It does require some additional knowledge of cardiology, neurology, and internal medicine that many of us, the reason that we didn't go into these, we went into EM so we didn't have to deal with these. But if you're going to do OBS, again, it's probably worth at least a brush up. And then I'll just quickly touch on emergency medicine versus staffing your observation unit with internal medicine or family practice. To give you an example from our facility, the average turnaround for a TIA CVA workup in our hospital was about 37 hours. Through our ER observation, it's more like 17 hours. So it just proves that we have a different mentality, and it's very difficult to teach that mentality to other service lines. So we at least have had, I know other observation areas may have had different experiences, but from our experience, we stick with the EM trained individuals. So from a reality standpoint, it will likely still require some hospital support unless your volume is just very robust. We suggest you probably contract for reflect minimum guarantees for provider support. Again, multiple wins for the hospital. It's kind of a no-brainer for them. Improve metrics, you expand their footprint, consolidated services, you decrease readmission rates, and again, huge area for potential fines for them. Increased observation facility reimbursement, you saw that trend line. It also helps with their audits. So the hospitals are getting audited pretty heavily for those true admissions that are staying less than 48 hours. So this is a way to potentially decrease their liability as well. And again, we're seeing much faster throughput versus the other specialties that run observation. As far as denials run, we're really not seeing any denials from a separate TIN pattern. The denials that we do see are very similar that we're seeing in the ER, whether they're combined sedations or procedures, etc. I'm not going to spend a lot of time on this, but remember there's a Medicare A and B. Kind of from this slide, the take home is the 2021 inpatient deductible is $1,484. Medicare Part B observation falls under that. So the patient is subjected to the 80-20, so they're responsible for 20% of that. They are responsible for, they recommend anyway, they take their own medications while they're in the unit as well. And kind of how this parlays out to the conversation with patients that, you know, because there's been some bad press to the ARP and whatnot about observation. And this is kind of how I talk to them. I say, you know, for the most OBS-related visits, you're going to be better off with the 80-20 plan. Unless your total allowable charges are above roughly $7,500, you're still going to be better off being in observation status. And unless it's a really complicated, robust observation stay, you're still probably going to come out on the back end. And remember that if that patient ends up being admitted to the hospital, that admission goes retroactive and the patient goes back into inpatient, so they won't be responsible for any more than that inpatient deductible. So this is where kind of the money is, right? This is additional opportunities. And this is something that we have to think outside of the box. This is where the additional, that 50, when we talk about that 50%, these are the kind of things that we have to look at. And one of the things you can look at is the sedation service line. Now we combine this with our observation unit to where if any sedation happens in the emergency department, we call down our observation provider under the different tin and we have them do that. As you remember that if you do a sedation, the classic shoulder dislocation, they're seen and evaluated by the EM doc. They get an EM level of procedural code, and usually if they bill out, they'll bill out a moderate sedation. Really not what we're doing if we're using propofol or ketamine. But if you choose to bill under anesthesia codes, you're going to lose the EM and the procedural side. So what we can do is similar to the OBS service line idea. You can have the ED doc come in and see them and provide the E&M level plus minus the procedure, and we can have somebody else from a different tin come down and provide sedation with anesthesia code. So capturing both things. As far as in the hospital, there's a great need for in-hospital sedation, whether it's oncologic procedures with bone marrow biopsies, whether it's CT guided biopsies down in radiology suite, MRI. There's the hospital transfers for orthopedics where they get a dislocation or a fracture that requires a pin placement that needs sedation. There's the potentials for INDs in the floor by general surgery. There's potentials for PICC lines and PEG tubes and, a number of things that require sedation. To be honest with you, for the most part, anesthesia really isn't interested in doing those. It's low-lying fruit for them, and it's just not worth their time. They rather spend their time in the operating room. So these are opportunities for us. Out of hospital too, again, depends how aggressive you want to be. There's outpatient MRIs that potentially people would need to be sedated for. There's dental procedures. There's outpatient surgical centers that do a vast array of outpatient procedures. Again, most of the time it's done by anesthesia, but we're seeing in our area that anesthesia just doesn't want to do these anymore. So again, depending on how aggressive you want to be, there's options out there. Now, you can also have a proceduralist service line. At our facility, patients will often sit up in the hospital floor for days waiting either IR or pulmonary or GI to do procedures like thoracentesis or paracentesis, where we can go up there and drop an ultrasound on, do a procedure like that, charge the procedure, and be happy with what we do. Emergent epistaxis care, this happens in the hospital. Just giving examples that, the internal medicine doc that sees epistaxis, I mean, that's deer in the headlights, right? They don't want anything to do with that. And likewise, what do? They consult ENT. Well, ENT is in the office during the day. They're not dropping their office to go take care of a nosebleed. Same thing in the middle of the night. They're not coming in the middle of the night to do it. For us, it's simple. That's our wheelhouse, right? Easy to do procedural codes. Line placements, same thing. Who's doing line placements in your hospital? Are they overwhelmed? Is that something that you can do? Laceration repairs, again, the patients fall in the hospital. They're pinched by guardrails. There's many times where they need laceration repair. Who's doing that? It's not medicine. So typically what they're doing is consulting general surgery. Same thing. General surgery has really no interest in doing that. That's not what they want. Potential procedures for us to do and capture. Blocks, with hip fractures, the fascia iliaca block is becoming more standard of care. Are your ER docs doing it in the ER? Great. If they're not, is this an opportunity to come down as a proceduralist and do that? Transfers in for hip fractures from outlying facilities that aren't doing those procedures, potential there. And again, all these may negate your need for support. Other additional lines, APM innovations, with the awesome model that's on the secretary's desk, we're going to own or be responsible for those potential Medicare patients 30 days after that ED visit. How are you going to do that? Are you going to do it through telehealth? Are you going to do emergency discharge follow-up clinics? That's an interesting thought. Early interventions and treatment failure solutions. This is a way that you can, have value not only to your hospital system, but to your carrier, where you can say, I'm touching base with them, and, the cellulitis that didn't get their antibiotics filled, or the patient that's not taking their Lasix for whatever reason for their CHF, we can intervene in 2 to 3 days versus them follow up in 2 weeks when they're decompensated and now they require a full admission. So lots of potential there. Again, MSW and ancillary services. Traditionally, those are owned and run by the hospital, but why? In the future, maybe those are service lines that we need to run through our ED groups. Same with care coordination. We talked a little about the implications of telehealth and what that can do for us. So again, the thought process, we got to think outside the traditional 4 walls of the emergency medicine or the emergency department. And if we don't, your revenue will fall. I mean, there's just no way around it. So what are some other potential options? Home hospitalization is going to happen. It is being instituted in several areas. Who's going to run that? Is that internal medicine? Is that family practice? From our standpoint, it's really an evolution or the next step past observation. We already have those protocols. To me, it only makes sense that we should be involved in some of that. Home triage services, whether it's through ET3 in the initial evaluation, telehealth follow-up, maybe home live evaluations. This is where that gatekeeper mentality comes in. And I think that once we can get buy-in from insurers and we could see that if we are truly the gatekeeper of that patient and they could touch base with us for any of their urgent or emergent care needs, if we're the initial touch base, we could coordinate, we could decide, yes, that is a laceration that needs care, but you can go to an urgent care for that. Or, that is something that you need to be seen in by a day or two, but your primary care doctor, I'm going to call them and make sure that you get follow-up instead of getting caught up in the phone tree that we all go through trying to reach our primary care doctor. So that's a huge potential. Same with self-funded employers. We could potentially get a per member per month fee for that, for being their gatekeeper, save them money, a low cost of care, a lot of potential there. Urgency centers. Now there's a CON need in Michigan. That's a little bit more difficult, but a lot of practices throughout the country have these centers. It may be an area where you provide your emergency discharge follow-up, maybe be a partner with your local physician organizations. Remember, our primary care our fellow docs are largely in high risk-based contracts. They want to do everything to decrease cost of care, and a lot of that revolves around emergency care. So if they could have follow-up at a center where it was low cost that you could run, that you could provide after hours care, a less costly ED visit, greater coordination with the primary care doctor, increasing their outcome, decreasing their readmissions, it's a win-win for everybody. It also allows you the potential of ownership of that facility, where potentially you could capture facility payments, which we all know pays better than professional fees. So it's a way to garner additional revenue. Again, you could also roll occupational health into that. Again, acute unscheduled care is a service, not a place. And I'm a firm believer that we are the people that are best at providing that type of care, either in the department or out of it. Other revenue opportunities amid COVID. I'm not sure what your hospitals are like, but there's staffing issues with hospitalists and ICU. We've been picking up shifts where we're actually doing hospitalist shifts as ER docs and ICU shifts as ER docs. We're providing line support and procedural support in the ICUs. Again, this is where our proceduralist services can come into play. Are you involved with the COVID triage testing and treatment centers? I know Dr. Gronofsky talked a little bit about yesterday about with our decreased volume and the fact that now there's potential IV treatments for COVID that require, close observation for potential anaphylaxis. This might be a way that we could work with our hospitals to say we're going to, take rooms X, Y, and Z, and we're going to make those COVID treatment rooms, and we'll staff that for you for potential complications. Basically, how you need to think is, what does your hospital system need? And, these are going to help solidify your contracts. And, the answer to any of their questions should be yes, and we can help you. Another option Dr. Adler talked a little bit about earlier was with MAT. It allows opportunities to improve your community, but it also allows an alternative career path. You can provide MAT treatment through in-person, but also telehealth. not only induction through the emergency, or not only initial treatments in the ER, but also follow-up. There are both inpatient and outpatient opportunities out there. Our group, for instance, runs several local methadone clinics and Suboxone clinics, and we're contracted directly through those clinics on a hourly basis. It's a day shift. A lot of people have great career satisfaction with that. Another way to garner additional revenue. Here's an additional thought. Most ED groups are a fairly established group of high earners. We have some discretionary funds. We're all looking for portfolio diversification. So what are we doing as a group to potential levy that? Potentially you could invest as both, is it corporate or as an individual or both? What are your goals, steady income or growth? But, I give you an example of certain groups are establishing LLCs. Their corporation is investing in this, and they're also allowing the individual docs to invest. Doesn't have to be medical, it can be retail, it can be real estate, but it's a way to, again, work at that 50% additional revenue that we're potentially looking at losing. So again, 50%, scary number, different. I know a lot of people have not thought about it that way, but I want you to think hard about this and think about this in 5 and 10 years is how much of your actual revenue is coming from just ED work. And if it is, what's your hourly revenue? And I hope that I'm wrong, but I would think that if you continue with your same model, you're going to see revenue decline going forward. Thank you.
Great. Thank you, Don. That was great. And just a note, yes, lawyers can be expensive, but we add value. All right. Folks, staff is going to take everybody off mute. I just posted a note. If you would please be mindful of that in the chat. If you're not speaking, please put yourself on mute. In the meanwhile, Mr. Thomas has something that he wants to share relative to the shared visit policies. And so, Todd, why don't you take it away, and we will be taking folks off mute as we go.
Okay.
So,
well, you said something in your presentation that kind of sparked that weird spot in the back of my brain that, stores all the minute bits of coding information I read through the course of a day. So if we look at CGS, Medicare MAC, about their shared services policy, and I'll enlarge this so it's a little bit easier to see, and we scroll down here to the bottom, they tell us that the following examples are not acceptable documentation for shared services. I've personally seen and examined the patient independently, reviewed the PA's history and exam, and agree with the assessment and plan as written. So they're telling us this is not appropriate documentation for shared services. And we have all preached that and followed that for years and have seen negative audit outcomes, specifically for groups that have used that exact language. But if we switch over to the WPS website that we see was updated in July of this year, and we scroll down here, and again, I'll enlarge this so it's a little easier to see. With the IOM requirements and CMS moving to reduce provider documentation burden, WPS would consider the following examples of medical record documentation adequate to support a shared service. I have personally seen and examined the patient independently, reviewed the PA's history and exam and MDM, and agree with the assessment and plan as written. So they've completely flipped the script. Now they're saying this is an acceptable example to support shared services. They do go on to say this information is specific to WPS and GHA, does not apply to comprehensive error rate testing, does not apply to the RAC contractors and other Medicare contractors. I think it's a little bit of a gray area, or it's going to create a stumbling block for us if we decide, well, okay, for WPS, we can use the generic attestation, but then who is doing audits for WPS? Well, it's their CERT contractors and it's their RAC contractors. So while on the surface, this feels like it might be a little bit of a relaxation of the requirements, I think in the short term anyway, it creates, kind of creates more problem than it cures. Because they tell us that, here at the bottom, review of medical records, shows an increasing number of ED visits that do not meet the guidelines. So I would encourage you, if you're not already, to bookmark the ACEP FAQs. I'm been tasked with updating the shared services FAQ for CNAC for this year. So I'll be going through all the MACs and updating that information. After the first of the year, you'll start to see not just the shared service FAQ, but all the ACEP FAQs are being reviewed and updated and getting posted after the first of the year. So like I said, I just wanted to share that, Ed, because like I said, you mentioned shared services. Yep. And like I said, we all have just a giant stack of, coding information that you read it and index it way back in the back of your brain somewhere. When you mentioned shared services, that went off, and I remember that from WPS. So I just wanted to share that. And like I said, if you have happened to see that, again, because that is your MAC for those of you in Michigan, right? That I would exercise some caution before just shouting from the hilltops, yay, we don't have to, we can do generic shared service statements now.
So Todd, you work with groups all over the country, and like I said in my talk, I could not find evidence that WPS has suspended TPE, even though I saw that with Novitas, I saw it with First Coast Service Options, and I was just curious, have you seen either a relaxation or a cessation of TPE activity with your clients?
So I agree with you. I haven't seen them publish anything that says they are stopping or postponing TPEs, but I also haven't seen any new TPE from WPS this year. So they may just are not doing it, just haven't publicized it.
Jason, David, have you heard of TPEs being active again? Some of the MACs not being clear that they've suspended activities during the public health emergency? Jason, we can't hear you. No. There you go.
I can tell you, sorry about that. Yeah, Novitas has suspended during the PHE, and they've been pretty good about abiding by that. Other carriers, more on the Midwest, a lot of the broad clients have not seen as much. Some are Todd's in the sense we haven't seen language saying things have been suspended, but we also haven't seen any activity during this time.
Right.
I would concur with that. Anything that was discussed in the last 9 months, I think was in place prior to the pandemic and the suspension of TPE.
Do we have questions from the group to any of the faculty?
Yeah.
I'm sorry, I was just noticing that when Ed is in straight talk, his Michigan accent comes back.
Don't you know?
Thanks, Ed. I have a question, or kind of a comment toward Don, and then just a question for the group as a whole. Thanks, Don, for giving that great talk on alternative revenue streams. I know my group in particular, we've actually had to cut shifts off the schedule just because with reduced volumes due to the COVID and some of the reimbursement issues that we're facing here in Michigan. It was cut shifts or, we're going to cut pay. So people would rather work less and work just as hard than, keeping the same number of shifts on the schedule. So one of the things that we actually just recently picked up with our COVID volumes going up is we took on a gatekeeper role for the hospital, which is essentially they use an emergency physician to essentially work on the hospital for downgrading people from progressive level units to regular medical floors, and kind of give them the power to make that decision unilaterally, even against sometimes the wishes of the admitting team, I guess, because as emergency providers, we're probably a little bit more willing to make decisions rather than just sit on people. So that was one way that we found an opportunity to do something outside the four walls of the emergency department and still provide benefit to the hospital. As we're getting sick COVID patients in, we need our progressive beds to be open to continue to use them. And then, having those beds open too allows us to have the flexibility with our elective surgeries if they end up needing, beds available. So that's one of the things that we found that we could do. And that's a shift that we've added onto the schedule every day of the week. So that's been really beneficial. And hopefully that'll be something we continue going forward. My question for the group as a whole is, as, you've had decreased volumes and you kind of had to remain flexible, what other types of service lines that they've gotten themselves involved with and what their experience has been like?
Don, don't you have some of the docs in your group that are addiction specialists? They got a special certificate in addition to the X waiver,
Mhm.
talking about MAT and creating that alternative service line. They're separately credentialed as addiction specialists.
Yeah, kind of as we saw this take off a few years ago, that kind of thought that might be something we would be interested in. So a few of our providers, went, in addition to getting the X waiver, are boarded in addiction medicine. So there was somewhat of a grandfather clause initially in that. So I think we have 3 that are boarded now, 2 more that are shortly going to be boarded. And that was able to parlay us into, some of our outpatient endeavors, but also we started an inpatient service as well. And again, I believe it was Jason that was talking a little bit earlier about the monies that were there from potentially from the state and national levels. And we were able to garner some of that money to start and use it to fund our initial inpatient service.
I think that's inspired, and then anything else I heard, I think, was telemedicine related.
Yeah, just an FYI to comment off of what Don just mentioned, that grandfather clause for the practice track to be able to get your board certification in addiction medicine, that ends this year. So you have 2021 is the last year that you can do the practice track where you don't have to do an additional fellowship. So that's something that you're interested in, especially within the state of Michigan. You can contact MI Cares, which is an organization that's through MSU that will actually assist you with getting the required documentation together to be able to get qualified to sit for your addiction medicine boards.
Yeah, we've had a couple of our clients that have tried to institute some telemedicine, and using some of the examples that Dr. Powell presented was that they've worked with local nursing facilities to set up a telemedicine visit and let the nursing facility kind of manage that for the patient. And so they are able to evaluate some of those patients, determine the need to be sent over to the ED or not. And I think it does cut down on some of those patients that can be safely managed that way with not having to deal with the transfer, bringing them to the ED, potential exposure. The only wrinkle is that if they do the telemedicine visit and decide, yeah, you do need to come to the ED, then it, standard coding rules is that all rolls into, the one ED visit. But then, there's obviously going to be probably a higher level visit. The other scenario that some of our groups have done telemedicine is just follow-up process, that they're given a specific number to call to if they want to do a follow-up. And then whoever takes that call will start the telemedicine process. Some of our clients didn't really understand telemedicine. They said, well, hey, we've heard about telemedicine, and so we're going to start calling our patients and giving them their lab results when they come back and bill those as telemedicine visits. And I said, no, you're not gonna bill those as telemedicine visits. He said, well, and so instead of just, I want to just call them and, go over their visit with them. And I said, okay, that's fine, but there's no way to capture that from a billing perspective. There has to be an account for that patient. So they can't just call up and say, hey, I want to talk to the ER doctor, and we launch that telemedicine visit. They have to be entered into the hospital system as they have an account, and they have to have a chart created. But they were wanting to do an addendum on the original visit, which isn't going to support that separate visit. So there does have to be a facility-wide plan and process in place to institute telemedicine.
So the RUC would consider that part of the post-service of the ED visit.
So let's talk about that, Jason. I know you've had conversations with some of your groups about that, and the idea is, patient is evaluated in the emergency department, COVID negative, but there's a need, because of the timing of the testing, the development of the disease, et cetera. There may be a need to do a follow-up encounter. Can you talk about kind of the logistics of kind of the patient consent piece, Todd's point about the charting, and then the billing of that, because it seems to me that doesn't fit into the 9928X codes, right? It's not unscheduled episodic care as defined by CPT. That's a scheduled visit. So then it would be an office code, presumably. Can you touch on that?
Yeah, absolutely. And first I want to comment on Michael's first comment about what we're seeing and the evolution. And really, I mean, this has been I always say it's been one of the toughest years ever, but you see the strength and value of emergency medicine, that we can make lemonade better out of lemons than almost any specialty out there. It's really beautiful. And we have this Darwinian pressure to evolve, because historically, we've always relied upon patients coming into us. And year over year, there's been more and more patients. The acuity's gone up, pay has gone up. Every metric that is meaningful has gotten better for us. And everything went to a grinding halt this year on volume. And in 2021, we have that, the reimbursements will be dropping across the board, right? Between SMB on the private side and the Fed cuts on the PFS side. And certainly Medicaid, we haven't touched upon that. And I apologize, I worked a shift yesterday, so missed yesterday, but I think there'll be Medicaid cuts. My most recent list has about 30 states have already announced Medicaid cuts starting in January 1. So every reasonable source of revenue is going to be dropping. And as a result of that, I think we've seen so much innovation within the specialty. So telehealth is one piece, and I'll answer your question about follow-up visits, but I've seen telehealth started to get involved in prisons and SNFs with EMS. We've got those programs that are out there. Don talked inside the brick and mortar walls of the hospital with observation, proceduralists, and things like that. Really well done, amazing stuff your group is doing, Don. And then also outside the brick and mortar walls, we've got remote patient monitoring, RPM, incremental revenue on a monthly basis, which is a really interesting code set for emergency medicine. And then of course, the follow-up visits. So the follow-up visits are born out of COVID, and a lot of groups have started with that. And I'm referring to big academic centers with very strong attorneys, and everything has been vetted. So I'm gonna sort of go against the grain slightly on this, Todd, because there's been differing opinions there, but groups have been making follow-up visits 2 days post, 3 days post an ER encounter using the same accession number within the MRN, making an addendum, processing it as an outpatient office code, as you mentioned, Ed, based on medical necessity, time, or MDM. It will fall where it does. I think most codes are between that 2 to 3 area, but we all know that COVID has a very predictable course, and there's time of exposure, time of symptomatology, and then time of decompensation. So there is a reason for medical necessity to follow up on patients after discharge. And if you can create a telehealth encounter out of that and go from the ED into someone's home, and they don't have to be in the ED. This is something else we've noticed, is that some docs are on quarantine, some docs are sick, APPs, same position, or you've got a telehealth center, a monitoring station where you can just reach out and set something up and see people after the visit. That's where it started. And then it evolved into things like what Don was mentioning with CHF, with pneumonia, the 30-day bounce back rules for the HRRP program. Just making sure that people catch their medications, people that are improving. I believe you do have medical necessity, and it seems to be working out fairly well, and it's being paid very well to the pro fee side. And then one final piece, and then I'll pull back. I'm really happy to hear what Michael had to say about your comments about what your hospital is doing. My system is doing the same on the clinical side. It's a little bit different, but you're the first example I've seen outside of our system. We have when you transfer into the mega centers, we've got a call center. You got people that are routing EMS and air choppers to pick patients up and bring them in. Our system has created a dedicated post that was designed for emergency medicine to sit at the transfer center. And we've got tracking boards across all 17 hospitals. We see every floor available, the nursing assignments. So it's not just bed capacity, it's actual real bed capacity. Who's COVID, not COVID. And we will pull patients out of certain rooms and put them into other rooms so that we get people from the community into our hospital. And it really speaks to the value that EM brings. I think we own acute unscheduled care, number one. And number two, we are very successful at air traffic control. We know where people need to go at the right place at the right time. And systems can leverage that resource, and it could keep us working in different ways. Long-winded answer, but hopefully I hit some of the notes.
Thank you, Jason. Todd, question in the chat for you about, can you touch on the modifier 95? Is it pro coding only?
So it's historically, I'm fairly well recognized or known to not know very much about facility coding issues. So I'm going to have to give you a fairly definitive, I don't know. It's one of those, facility coding is one of those areas where I know some key phrases and I know the lingo, and so I could sound like I know what I'm talking about, but I can assure you that I don't. So I'm sorry, I'll have to, on the using the 95 for the reporting the facility services, I'd have to defer to somebody else because I don't do anything facility related.
I would say similar. I don't hold myself out as a facility coding expert, but in the CPT Appendix A, the 95 modifier is in the professional, not on the facility side, or not in the section for facility modifiers.
All right, Sandy, I see you there. You want to take yourself off mute and ask your question to Dr. Powell?
In previous years, we've had a Michigan update section, which is really only a 10 or 15 minute constrained to, what Michigan Medicaid's going to be doing next year, what Blue Cross of Michigan will be doing next year. Is there anything that you have that typically would have been gone over in that conversation for pertaining to specifically Michigan that's going to be happening next year?
I think that we all are very concerned with the budget issues with Michigan and there potentially a budget cut through the Medicaid services. As I am not aware that anything's been officially announced yet, but obviously that is one of our biggest concerns. To what extent and how that applies is yet to be determined. So yeah, I think we're all very concerned that we're going to see an adjustment. Now, where that lies out, I'm not sure. Now, this goes in perfect correlation with what Ed was saying about Lisa Maurer's group through Wisconsin and how they were able to engage with their legislators early on to gain potentially or garner additional funding. I'm hoping that through MSEP we'll have similar early negotiations or talks with them so that potentially we could either look to garner funds or abstain, cuts being frontline workers. So to be determined, I guess. Yeah.
Okay. And what about the auto reform laws that were passed in Michigan this year? Are those auto insurers now coming under the surprise medical billing that Governor Whitmer signed? So is that going to be impacting our collections then from the auto insurers as well as all the other health insurers that we don't par with?
Yeah, I do not know. Don, go ahead.
No, I was gonna ask you. I was gonna say I was gonna refer to you on that.
Now, Sandy, I mean, it's definitely something to look at. Typically, in the bills that I've seen in the past, those laws specifically exclude Medicaid, auto, workers' compensation, those types of plans. But I don't know specifically about Michigan's bill.
Okay.
See in the chat, John Holstein's bringing up the awesome model. I think Dr. Powell mentioned that. Lisa Maurer is leading a group of reimbursement committee, coding committee, state legislative regulatory committee folks to really do a push towards introducing Medicaid providers to the awesome model. And I think that they're interested in that in a way to save money. To Dr. Powell's point, it does allow telemedicine. It does allow kind of a modified home visit, a paramedic or somebody goes out and sees, but it has to be data-driven based on the conditions that are covered under the agreement, and it may be specific to each individual Medicaid program. So the model is there. There's a lot of information on the ACEP website if you're interested in that, but we are trying to find a way to make the Medicaid plans more aware of awesome and use that as an opportunity for alternative revenue streams.
Any other questions in the chat or otherwise?
Mr. Gaines, I just want to apologize again for missing Straight Talk last year because I was in Egypt. And so here's your, actually, I'm going to be the Sphinx.
Do you have the camel picture handy, David?
I'll see if I can come up with that. That was a
particular favorite of mine.
Yeah. Ed, I just wanted to add on a quick comment here, kind of reflecting back on Sandy's question. And one of the things I saw in the chat was if there's anything going on with Blue Cross this year as well. And this is something I don't think we touched on this year. But MSEP is currently meeting and discussing with Blue Cross, because what we've seen is that they've released a letter of notification to certain groups across the state that they're going to start using this modification of the NYU Edie algorithm,
Yes.
which is essentially to look at, based on discharge diagnosis, what is, is this something that really required, a 4 or a 5 level service? So, if it was an ankle sprain or sinusitis, for example, if they pick that up and according to their algorithm, if they think that should really be a 1, 2, or 3 versus a 4 and a 5, then what they have been doing is just frankly denying the payment, sending a letter to groups to say, please provide additional documentation, and then we'll essentially look it over and then renegotiate the coding from there. So, what's interesting is the NYU algorithm very much, it says right in the initial paper that studied it, this is not to be used, for any sort of reimbursement purposes whatsoever. So they're aware of that. They just don't care, frankly. So we've been working with them to try to understand what their process exactly looks like. And then, I think what we may end up, figuring out in the end is, essentially, do we just have to be, mindful of the way that we're, documenting our discharge codes? Is there certain things that are going to, bill for a 4 or a 5 where you're really talking about the same thing, but depending on which, ICD-10 code you assign to it, that'll then determine whether or not you can bill this out appropriately. And we're providing appropriate pushback as well, because, once again, this algorithm was not really meant to be used. And, frankly, rather than, going to just say, hey, we really think this should be a 3, so let's pay you at a 3 and then renegotiate from there. Denial of payment doesn't really feel appropriate. So MSEP is currently working on a series of meetings where we're, coming back with additional pushback. One of the things I could offer up to the group is if you do get any denials from Blue Cross Blue Shield that, maybe based off this algorithm, please email us, with an example of that particular case to the MSEP office, so that way we can use that as ammo when we go back and show, how inappropriate this was, or, that the care was really appropriate at a level 4 or 5, but their algorithm approach was not appropriate. So we appreciate any information that people can send to us.
So great. Go ahead, Sandy.
Sorry, Ed. Are you seeing that just in the, the notice that I got seemed to indicate that it was just going to be like their Blue Cross and their Advantage plans, but are you seeing that coming through now on commercial plans as well for Blue Cross?
It seems to be Advantage plans at this point in time, but this also seems to be something that's not just happening in Michigan, it's happening in several other states. Like essentially, this is something that's just, it's the popular thing. So it wouldn't surprise me, especially if they do see, these Advantage plans, have decreased payments that they're putting out, that they would then expand them to their other commercial plans as well. So I think this is something we just gotta, have early pushback on and appropriate education on their side, how this could potentially be harmful to the patients.
So that Dr. Gratson, Dr. Zach Giroux did an extensive PowerPoint presentation on the NYU algorithm to the reimbursement committee. David may remember, I think it was November. And one of the things that my work group of that committee is looking at is how can we develop some specific talking points that might go into a letter to Blue Cross. Zach really did a nice, really, really good job, a deep dive in analyzing, some of the comments and the studies that prove the very points that you're talking about. So that may be a resource to you. I know
Zach actually has been helpful.
Good.
He's been on these meetings with us. So.
Good.
Right.
Excellent.
He's
Excellent.
been added to our leadership for these meetings. This is Belinda. So
Yeah.
we're trying to get a date for January 2021 to discuss.
Great. All right. Well, I see that we're right up on the half hour. And I just want to add my thanks to all of the faculty and to the staff and our sponsors, and certainly to all of our attendees. It's been a difficult year. I didn't say this at the outset of my talk, but I dedicate what I do to all of you clinicians and your frontline care teams. Thank you for what you do. And if we can help you just a little bit in your practice areas, in your coding and billing, it's our honor to do so. So Dr. Gratson, I'll hand it off to you.
Well, thank you, Ed. And, I just really have to echo your sentiments. As we started the conference, we highlighted that it's been a difficult year, and the path in front of us is difficult. But, there's a sense of pride that we can take in emergency medicine, and knowing that when disaster strikes, when the public is facing a crisis, we run to that front line. So it just really highlights how important the work is that we remain, financially strong, financially viable, that we can be able to staff our emergency departments well, that we can continue to attract the best and brightest, in medicine to work in this field and really provide that excellent level of care. So, thank you to our sponsors, here today in Logix Health, Gottlieb, Zotec, and Pro Insurance. I said it a couple of times, without, the help from our sponsors, we wouldn't be able to host this conference. Thank you for, the lectures that were provided here, in the high level of education that we were able to provide out to all of our presenters. And, thank you for all the attendees that came here today and to learn from this. This is how we continue to keep our specialty strong. This is how we continue to make sure that we're ready to charge into that front line whenever there's a crisis there. And then, I can't ever say this enough, but thank you, Belinda, Maddie, and Christy. You guys at the NSIP office are, without you guys, we wouldn't be able to figure out any of this stuff. And none of this would be possible. Truly, none of this would be possible. So thank you again. One last piece before we sign off is just for CME, keep an eye on your emails, as you will get a link to the survey that's required to be able to get the CME. So make sure that you go forward and complete that. And, I'm looking forward to seeing all of you guys in person next fall. I think the light is here at the end of the tunnel with these vaccines rolling out. Just can't wait to actually get back to in person and to see everybody's lovely faces and to be able to, really have that human-to-human connection again. So, thank you guys. Look forward to seeing you all again next year. And everybody have a safe, holiday season. And yeah, thank you again.